We've been dealing with some technological issues here, so I'm looking at the presenter chat, or if somebody can chat to let me know you can hear me before we dive in and I tell you all the amazing and important things about this. Yay, you can hear me. Thank you. I appreciate that. Awesome. All right, great. So good morning or afternoon, depending on where you are, or let's be ambitious and say evening. Who knows how far this is going. I am Kate Hardy. I'm a clinical psychologist and clinical assistant professor here at Stanford University, and have been very lucky to be asked by SAMHSA and INTAC to pull together this information on positive practices for working with psychosis. This is a 3-hour webinar, and what our intention is to break that up over the course of the 3 hours. So planning to go to about 50 minutes, break for 10, another 50 minutes, have another break for 10, and finish around 12 p.m. PST. Basically because it seems like an awfully long time for people to just sit and look at a computer and hear my dulcet tones. And also a long time for me to talk without stopping. So wanting to make sure we have a bit of a break in there. Other logistical things, many of you have already discovered the public chat. There will be opportunities for folk to respond to questions as we go through this, so please do feel free to use that. Also feel free to ask questions as you think of them. I'm also going to be trying to break and just respond to questions as we're going through this. But do feel free to be posting questions. Ryan Melton is going to be monitoring the questions as well, so that he can flag anything that needs absolutely immediate attention. I don't think there's any other logistical pieces. If they are, the person named the Institute in a kind of ominous way on the public chat is a really great resource for answering those things, so thanks for that. All right, so let's dive on in. Oh, nearly forgot. And there's a survey at the end of this that they would like you to complete, and I think there'll be a reminder as we're finishing up as well. So, yeah, there'll be a survey, which I will try to remind you to do, but if not, I'm sure somebody else will jump on that. And final point, I think you should see as well, down at the bottom of the screen, or at least it is the bottom of mine, files, or an area called files, and that holds the PDF version of these slides, so feel free to click on that and download if you need to, or if you want. So with all of that said, let's go ahead and dive on in to this topic. So just kind of thinking about a little bit of background here. This is being hosted by ESA, and who are a partner from the National TA Network. And as I mentioned, I was asked to pull together this training or this workshop on kind of CBT-informed skills for working with psychosis. I think a couple of years ago now, yes, it was a couple of years ago, I actually did a 3-session 3-hour webinar, so yeah, three hours, on CBT for psychosis from more of the full model. And what this one today aims to do is to take some of those sort of key principles that we apply in CBT for psychosis and think about how the key principles, the skills, can really be applied to anyone working with individuals with psychosis. So this is about sort of taking these skills out of the therapy room and into the real world. So the objectives today are to introduce this concept of what we call positive practices for working with psychosis, to learn the principles of what we call the first model, and I'll talk through that a little bit more in a bit. Think about the skills in engagement, curious questioning, basic formulation and intervention. So these, what we really think about as sort of fundamental skills of this approach. How might these then be implemented in a real world setting, in a community-based model, and then talk about this real world implementation and sustainability. And like I mentioned, I'm going to try and make this as interactive as possible, more challenging in a webinar setting. So I'm going to assume that you are all familiar with psychosis, but just to make sure that we're all on the same page and so you know that where I'm coming at this from, when we think about psychosis, we think about psychosis as being a temporary state of mental impairment marked by a loss of contact with reality, causing impairment in functioning. It's a fairly typical definition, and we could have a whole webinar in and of itself on that definition itself. We think about psychosis as also being an umbrella term for a number of different experiences where a loss of contact with reality is a prominent feature, and as you see there, this goes across a whole range of diagnoses, typically and most often schizophrenia and schizoaffective disorder, but we certainly see psychosis as being a feature of bipolar disorder 1, delusional disorder by definition, very commonly associated with PTSD. In fact, we're becoming much, much better at recognizing the links between trauma and psychosis and the need to be able to treat both. Again, a whole different webinar in and of itself. Major depressive disorder may often have features of psychosis in certain personality disorders. So that's just to give this kind of overview of what we talk about when we think about psychosis. But the other really important piece of this is sort of conceptualizing psychosis as existing on a continuum. For the longest time, we thought about psychosis and about those diagnostic labels as being discrete entities. Either you had psychosis or you didn't. Either you were psychotic or you weren't, with not much in between. And it's only really relatively recently that we've begun to conceptualize psychosis as existing on a continuum. So my walking brain there, which I know looks like a peanut, but work with me here, it's a brain, is moving up and down this continuum between no psychosis and full psychosis, really demonstrating that any one of us, given the right or the wrong conditions, could experience what we might term psychotic-like experiences. And things like stress, drugs, trauma, life experiences, sleep deprivation may move us up that continuum, and dealing with those may move us back down. Now, obviously, we think about psychosis from the sort of psychosocial perspective, while understanding and recognizing the biological underpinnings and genetic underpinnings of psychosis. But here what we're thinking about is what are the factors that may lead a person to experience an exacerbation of psychotic symptoms? And when I say a person, I mean basically anybody. So a good kind of exercise to think about here is to think about your own lives and to think of times when you yourself might have experienced inexplicable events or experiences. Good examples might be when you thought your cell phone rang and you went to check it and no phone had come through, for new parents thinking they heard a baby cry or their baby crying and then going into the room and the baby's fast asleep until you go in the room, of course, and then the baby wakes up. And we know that these are often associated with sleep deprivation, with stress. If you're expecting an important phone call to come through, you might be more kind of hypervigilant to that. Stimuli might become more hypersalient, and then you think you hear that. So we know these experiences are very common. The reason why we talk about this within the context of a treatment approach is this really began to help us think about how we could apply what were well-established therapy approaches to individuals working with psychosis. So it demonstrated a shift in how mental health professionals thought about treatment of psychosis. When we think about it as this discrete entity, as being psychotic or not, if we think about it being entirely biologically oriented, then it becomes much harder for us to see a role for talking therapies and for the skills that we'll discuss today. But when we think about it as being on a continuum and see things like stress, trauma, life experiences, sleep deprivation, other things as being factors in the exacerbation of psychosis, then we start to see that actually there's a huge role for mental health professionals to play. And actually we'll come back to this kind of normalizing idea later in the call as well. So what is this thing that we've called positive practices for working with psychosis? Well, this was really developed out of the recognition that there's a need for frontline providers to have additional skills to work with individuals with psychosis. We often think about these frontline providers as being the people who spend the most time with individuals with psychosis and yet have had the least access to specialized training in these models. And when I talk about frontline providers, I'm thinking about case managers, I'm thinking about nursing staff, I'm thinking about peer providers, essentially anybody whose role is not the typical sit down and do a traditional therapy session. This approach is very much based on a cognitive behavioral therapy model, and we'll talk more about what that is in a minute, and draws upon sort of wellness orientation and recovery orientation and recovery language. Its focus is on the application of skills that have been shown to be effective in CBT that can be used in routine interactions with clients. So again, it's about how do we take this out of the therapy room and into a real-world setting. And then the consideration of skills and tools to support mental health of frontline providers and reduce burnout as well. So how do we apply these CBT skills to ourselves as providers? How do we recognize when we ourselves are getting overwhelmed or anxious or stressed in given situations? And can we apply these skills to recognize our own thoughts and behaviors in those settings? Now, every good model needs an acronym. I think that's sort of Psychology 101. And as we were developing this positive practices for working with psychosis model, I thought that we needed to have something that was going to be catchy, that was going to really help individuals remember the phases or the steps involved. And so through the process of throwing a lot of words on a piece of paper and figuring out all the different pieces of this model, we came up with this acronym called FIRST, which we break down as these 5 steps where we need essentially at the very start to have a strong, good relationship. So we really emphasize the need to form a relationship with the individual that we're working with, developing shared goals, normalizing experiences. We then use that relationship and draw upon that relationship to really inquire curiously about the person's experience. So asking questions and dropping assumptions through that process. Then using the information gathered from the questioning, we want to review that information and pull it together. And this is sort of, in essence, the formulation piece, the way of sort of understanding the experiences in a shared and collaborative manner with the client. We then use that formulation to identify and drive what interventions we want to work on, and so developing skills and tools to support the goal attainment, and then trying out the skill and eliciting feedback is the final stage. So it's all well and good if we've talked about it and we've got a good idea of what's going on and we've identified what we could do about it, but unless the client is being encouraged to try out the skill in the real world, and then we check in and find out how that went, then it's not really going to go too far. So that final step is a really important piece to help us make sure that the skills we've talked about really land in a way that's going to be meaningful for the client. Also called homework in the CBT world, but calling it homework is often not the best idea. I'll talk about that later as well. Excuse me. So again, just to make sure that we're all on the same page, and I know for many of you this will be an overview or a quick recap, but I just want to talk about what the CBT thing is anyway. So when we think about CBT, we're really focusing on how we think about something, and how we act or how we behave impacts how we feel. And thinking can include how we think about ourselves, the world, and other people. It's typically based in the here and now, in kind of the current situation, but we do draw upon past experiences to explain schema formation or core beliefs. And we won't go into that too much today, but I just wanted to highlight that that is a piece of what we do in CBT for psychosis, because it's very important for us, particularly I think working with psychosis, to understand how some of these beliefs and experiences have been formed based on their past experiences. And this will be a very familiar sort of triangle to all of you, I'm sure, kind of the link between thoughts, feelings, and behaviors. Now, when I'm starting CBTP with a client, I really want to help the client to understand and to be on the same page as I am as to what this CBTP thing is. And so we want to essentially socialize the client to this model, help them understand the link between thoughts, feelings, and behaviors, and help them make those kind of connections. It should be, and usually is, a very transparent and collaborative approach. In fact, I think that's one of the real strengths of CBT and CBTP, that you're working in collaboration with the client to sort of form this understanding. There's nothing kind of hidden. There's no kind of smoke and mirrors approach here. There's no moments of the clinician going, aha, I understand you, and sort of putting forth some sort of interpretation or insight into the client and hoping that they nod and see you as the best psychologist in the world. Instead, it's really about trying to figure it out together. And so I'm saying that because at the beginning of sort of the process of doing this with the client, what I'm trying to do is get them on the same page and understand the links between thoughts, feelings, and behaviors. And so I might provide an example up front, or a kind of a model to help a person see how does this all link. So a typical one that I may use would be to sort of say, imagine that you're falling asleep late one night and you hear a loud crash. What could make a loud crash? If we're all in the room, I would ask you all to give me possibilities, and that can go on for many hours depending on how creative the group can be, because I only have 2 pictures on here. But for the sake of time and limited technology, I will give you an answer, which is, what could make a loud crash? Well, it could be a burglar breaking in. And so in our example with working with a client, we would say, so if it's a burglar breaking into your house as you're falling asleep one night, how might you feel? Might feel afraid, might be petrified. What might you do? I've heard lots of wonderful answers to this over the years as I've been given these examples. But you might hide under the covers. That would be totally me. Or you might be reaching for the baseball bat. You might be calling 911. So you think it's a burglar, you feel afraid, you hide under the covers or call 911 or whatever. However, if your first thought is, my really dopey-looking cat knocked over a Ming vase, then your reaction is going to be different. So the thought is, it was my cat. The emotion is frustrated, relieved, no, probably not relieved, frustrated, maybe startled. And the behavior, well, get up, put the cat out, clean up the vase. I've heard some worrying things about what should be done to that cat over the time that I've been given this example. But essentially what we're saying here is the same event occurred, the same large bang. How we interpreted this led to a different emotion and to a different behavior. And so I'm using examples like that to help a client get that link. Now, this also can help us start to think about how other factors might influence how we think about the world. So we might want to think about how the environment will influence the interpretation. So if you live in a neighborhood where there's been a lot of break-ins recently, then your first thought might be that this is a burglar, even though there's no evidence to support that. So you might jump to that conclusion based on the kind of contextual information that you're faced with. We might also want to recognize how the past would influence that interpretation too. So if you had a traumatic event or a number of break-ins in the past as a child, or experiences of feeling unsafe, then again, you might jump to that conclusion of it being about a burglar, when in fact there are other explanations that were available to the individual. So there was really thinking about how both kind of environmental factors and past factors will influence how we interpret the world around us in that moment. Before I move on, I just want to make this kind of, what's the word I'm looking for? Explicit description of the difference between thoughts and feelings. And I know, sat there going, well, I know the difference between thoughts and feelings. Indeed. Although actually, if we get into it, it can get a bit complicated. But typically, we know the difference between what is a thought and what is a feeling. A feeling is an emotion. It's typically a single word. A thought is a way of defining or interpreting the world around us. But here, certainly in North America, and certainly other countries, other English-speaking countries, I wouldn't know about non-English-speaking countries, we kind of get tied into a knot when we use certain language. So I feel angry is an emotion. I feel like things aren't fair is actually a thought. but we use the vernacular often of saying, I feel like, and so it can be very easy for clinicians and for clients to label those as emotions. I thought it was scary. Could be a thought, could be a feeling, probably more likely to be a feeling. I feel freaked out, works as an emotion. I feel like you're being a jerk, definitely a thought, but can easily be mislabeled as an emotion because of that I feel like piece. Now, this is important because, again, as we're helping people to learn the skills of CBT, what I like to think about is that we're really helping them become their own therapist. So my goal with every client I see is that I ultimately am going to get fired because at the end of it, the client is going to know how to be their own therapist far better than having me as their therapist. That's kind of an interesting goal for every clinical interaction I go into. I'm aiming towards getting fired at the end for this reason. So we need to be careful about the language that we use and help a client to label this accurately, because some of the interventions that we'll talk about later really hinge on accurately identifying a thought and then being able to explore that thought. And if we're mislabeling emotions, it becomes a little harder to do that. So I just want you to keep that in mind as we go through this. Excuse me. So I've given you that overview of CBT and just what this kind of model is and all of that. I'm going to now try and couch that a little bit more in the world of psychosis and how this applies to working with individuals with psychosis. So from a historical perspective, this approach was first described by Beck back in the 50s. However, CBT for psychosis was actually really overlooked as an intervention for many, many years, and it's only really been in the last 20 years that we've been thinking about how to use psychosocial interventions like CBT to support individuals with psychosis. And I think it's been largely overlooked as an intervention because, as I mentioned earlier, the kind of prominence of biological and medical models. So if we purely see psychosis as being a brain disease or a brain disorder, entirely due to changes in neurotransmitters, for example, it becomes harder for us to see a role for psychosocial interventions. And so, like I say, there was certainly shifts in how we consider and think about psychosis that helped us recognize more of a role for these interventions. There were studies in the 80s that reported that talking therapies were at best ineffective and at worst damaging to individuals with psychosis. And then this long-held assumption that somehow psychosis lies outside of the realm of normal psychological functioning. If you look back at some of the early psychiatrists that described psychosis or schizophrenia and the different names it had back then, you would see that as being sort of one of the caveats for understanding psychotic disorders. And I've heard this sort of termed a therapeutic nihilism, because all of our sort of therapy interactions with clients really hinge on the ability to create a therapeutic relationship, and we'll talk about that later. But if we see that psychosis as somehow being other, as being different, as being outside of the realm of what is considered normal psychological functioning, it becomes much harder for us to approach a therapeutic relationship. However, if we think about the continuum that I just showed you earlier, and see this as being on a continuum of normal psychological function, if we keep using that phrase, although we can certainly argue what normal pertains to, then it becomes much easier for us to find common ground to form that therapeutic relationship. So when we think about the CBTP approach, this focuses on reducing the distress caused by positive symptoms and increasing functioning. And it's a really key piece that we're really focusing on reducing distress. We're not actually focused on reducing symptoms. So the outcome isn't, is this person experiencing less hallucinations, but rather, is this person less distressed by their hallucinations? Now, the problem has been, unfortunately, if you read any paper or article written on CBTP, the reported outcomes are always symptom reduction outcomes. And yet, I can guarantee you could ask anybody working in the CBTP world, and they would say that the primary focus is distress. When we are working within this model, we actually have kind of two lines of potential for intervention, which is, again, something that I really like about this. We can work with the individual with their thoughts. And as we've just seen, it's the interpretation of the event that causes the distress rather than the event itself. And here we might be helping the client to check the accuracy of their interpretation. So, for example, if you have a client who comes in and tells you that they're being followed by the FBI because they saw 5 blue cars passing their window this morning, then we might be helping a person explore that belief, look at other reasons why there might be blue cars. Was it the same blue car? Were they different blue cars? Why is blue meaningful to this client? But we also have the opportunity to work at a behavioral level as well by examining and exploring how do current behaviors potentially maintain the problem. And once we've identified that, checking the helpfulness of these current behaviors and seeing if there are other behaviors that can be implemented instead. So an example here might be a client who's experiencing auditory hallucinations and spending their time in their room engaging with the voice at the expense of doing their activities of daily living. Again, we want to think about the helpfulness of that and maybe negotiate and explore the possibility of spending 30 minutes doing the laundry and the rest of the time talking to the voices, for example. So it allows us to work at both the thoughts and the behavior level. And I just want to say I think that's really important because not everybody, and this is not just about psychosis, this is just about anybody, the general population, not everybody finds it easy to think about their thoughts. In fact, when you think about thinking about thoughts, there's a brain scratcher for you. It actually gets a bit confusing and it gets kind of hard when we think about sort of metacognitive stuff. And so, having this other opportunity to sort of work at a behavioral level can be really helpful as a way in for interventions. The other piece that I also really like to emphasize at this point is that the thoughts and the behaviors allow us a way into the emotion. And again, I will, as I'm describing this to families or to clients directly, I will ask and I'll share, has anyone ever told you to cheer up? Or don't worry, how effective was that? And typically people will say, it wasn't, it doesn't work. And then I share with them that that's true because if it did, I wouldn't have a job. No mental health professional would have a job if saying cheer up actually worked. So we know that we can't just change emotions with a single phrase or, the click of our fingers. But what we can do is help the emotion to change by going through the thoughts and the behaviors. That's another reason why we want to think about these different levels and layers. I'm going to be talking specifically about positive symptoms for psychosis today and thinking about skills to support those, so hallucinations and delusions primarily. But I do want to say that overall, when we're using this model and this approach, that we have other target areas. So just because somebody has psychosis doesn't mean that they don't also have depression and anxiety. In fact, they're often comorbid. So we might be wanting to apply CBT to address that. As I mentioned earlier, we're getting much better now at recognizing the link between trauma and psychosis and addressing that in intervention as well. We might be helping around social skills or addressing negative symptoms, supporting problem solving and decision making or coping skills or wellness planning. So even though we're just going to talk today about the positive symptoms, there's this whole range of other things that we can also be thinking about and focusing on as well. Now, primarily, the focus of this call and the work that I do is around early psychosis, but I wanted to talk about these different stages of applying CBT in a kind of more general terms. Whenever we try and put things in pigeonholes like this, there's always clients and individuals and people that don't fit into these labels so easily. But sort of generally, these are the sorts of things we'll be focusing on at each stage. So for those individuals who we might identify as being at clinical high risk for developing psychosis, and for those of you that don't know, this is a group of individuals who are demonstrating what we would call attenuated psychotic symptoms. So they're not yet fully formed enough to say this is full psychosis, but it's enough for us to sort of be able to say, well, if this was to develop and go further, it might look like full psychosis. So an example might be the difference between a client or an adolescent sat in the back of their classroom wondering if the teacher can read their mind, kind of getting a bit distressed about it, kind of preoccupied, ruminating on it, but able to shrug that off eventually and sort of say, yeah, you know what, probably can't happen, versus the same person coming into the class a few weeks later or not coming into the class because they're absolutely certain that the teacher can read their mind, and they're now taking steps to avoid that, so avoid the classroom, avoid the teacher, maybe wear a tinfoil hat to stop the thoughts being read, whatever. The difference there being between a conviction and behavior. So we see the full psychosis happening when there's full conviction, and it's having an impact on functioning. So for this clinical high-risk group where there's these attenuated symptoms, we're really trying to focus on those attenuated symptoms, testing out and developing new explanations for the experiences. We might want to address comorbid anxiety and depression, and because this is typically a younger population, we're also thinking about school and peer functioning and helping a person really maintain those roles. We see, obviously, because of the conviction piece, a lot of cognitive flexibility around the experiences, and so using a lot of the traditional CBT techniques to support that. Within early psychosis, so individuals with first episode psychosis or early in the kind of psychosis trajectory, we're going to be addressing acute, fully psychotic symptoms, developing explanatory models and beliefs around psychosis and stigma, exploring those and seeing if there are different ways of thinking about this, discussing the role of medication and what it means for a young person to be taking medication, and really involving families in this process too, and actually involving families in the clinical high-risk phase also. For somebody who's got a more established psychosis, who's maybe been managing the symptoms or experiencing the symptoms of psychosis for much longer, the focus is often on wellness planning, developing and refining the coping skills to support that, and addressing the functional goals that the individual has. So how do we support functioning despite or in line or along with the individual's beliefs about the world and about themselves? So is there any evidence that this CBTP thing, particularly around informed skills, is useful? Well, I will say that using CBTP-informed interventions is much newer. So like I mentioned, CBT for psychosis has been around for sort of 20 years or so now, and there's a number of meta-analyses and a number of research studies that demonstrate how effective it can be in reducing positive symptoms, negative symptoms, and improving functioning. However, these informed interventions, this kind of way of taking the skills out and putting them on the front line, is a much newer model and approach and initiative. Doug Turkington and Harry Sivek over in Ohio in the Best Center developed a CBTP-informed intervention training, which they piloted on 13 case managers trained in the CBTP, T small there. Patients showed clinical improvements on general symptoms and hallucinations, suggesting benefits and safety in training in high-yield techniques. Also just really demonstrating feasibility that case managers could be trained to fidelity in this approach. And then Chang et al. Trained staff in a long-stay unit and recovery-oriented cognitive therapy, which is really this milieu-based intervention. And there they found incidents of seclusion and restraint reduced following an 8-hour workshop, which is fantastic because typically when we think about CBTP training, the full training, it's a minimum of 3 days training plus follow-up supervision and consultation and tape review, so very, very intensive. So the fact that they were seeing these nice positive outcomes after just an 8-hour workshop of really targeted skills is really encouraging. Inset al. Looked at CBTP implementation in the UK, where there's been a large national drive to ensure accessibility to CBTP. So the national guidelines on treatments for individuals with schizophrenia has really emphasized the need for individuals with schizophrenia to be able to access at minimum 16 sessions of CBTP. So along with that drive, there's obviously been a number of studies that have looked at how well this has been implemented. And they really recommended that services offer both this full formulation-informed approach to CBTP and CBTP-informed care in a sort of tiered treatment model. And stating from that it really allows for treatment choice based on individual needs and preferences. So what we see is that not every client wants to go into the full CBTP therapy approach, but could potentially still benefit from and would like to engage in more of the skills. And so that what a tiered approach might look like is something along these lines of sort of training all staff in just psychosocial intervention, ensuring staff are trained in engagement, rapport building, with a wellness and recovery orientation. Kind of the next level up is training frontline providers in the skills that you would get with the psychosocial intervention training, and helping the individual to understand voices, distressing beliefs, developing brief interventions and implementing these skills. And then the top level is this formulation-based CBTP, which incorporates all of the skills below, plus more complex assessment and formulation, and may be delivered by licensed therapists for whom it is their role and job to deliver a course of therapy. Excuse me. And then this final piece that I want to sort of introduce and talk about in terms of sort of the research base is these top 10 tips for ethical and competent CBTP that Alison Brabham and colleagues wrote last year. And it's a really nice paper. I really like this because it recognizes that CBTP, when applied as a panacea, becomes potentially ineffective and not as individualized as we would like it to be. And so they really address that by thinking about what are the important components that we need to be providing. And this also helps to inform these CBTP skills. So we really want to ensure collaboration. As I said, this is a highly collaborative model, and I'll talk more about that as we go into the questioning. We're using everyday language and accessible language. So in that, what I really feel is that we're able to drop the expert role in the collaboration and using language that we can develop a shared understanding from. We recognize the historical context of a person's experiences. So even though we're focused on the here and now, like I said earlier, we want to understand how these past experiences informed how the person interacts on the day-to-day now. We're evaluating and exploring appraisals and beliefs. We're not challenging them, and this is a little bit different to sort of traditional CBT models where you'll hear language such as challenging thoughts. Now, that might work really well and fit nicely in a depression and anxiety model. I find that less helpful when we're working with psychosis, where a client often will come in expecting to be challenged because they've been challenged so much, and already we're set in sort of opposing corners. And so using the collaboration, what we can do is be much more exploratory together, kind of going on a voyage of discovery together and sort of dropping our assumptions through doing that, both myself and the client, rather than going in with this idea of you're thinking wrong, I need to challenge that and help you think differently. I don't feel like that gets us very far, particularly working with psychosis. We use the stress vulnerability model a lot to understand psychosis and psychotic disorders. But they caution the overuse of that, and they caution really checking in as to how that's being received by the client when using certainly language like vulnerability, if that's being interpreted or internalized as somehow being vulnerable or weak. So really sort of checking in on the messaging around that. Validating the client's experience and ensuring that we deliver hope through the process and the intervention. Offering informed choice, that might be going back to what types of interventions do we want to, or what level of intervention do you want, skills or the full CBTP, or is it about offering informed choice about what direction we go in next? You know, which area of which problem on your problem list would you like us to focus on today? Ensuring adequate training and adequate supervision for clinicians working in this model is also kind of essential in this process. So I got through all the kind of the dry and boring research bit, which is awesome. I always feel glad to get that out of the way because what that means is we can actually now get into the more fun clinical stuff. As we do that, I just want to take a pause for a second because I see a question has come up, and I want to offer the opportunity for anyone else, if you've got questions as I was going through that kind of research, evidence-based stuff, or if there's other things, feel free to type that while I just answer the question that already came in. So a question that came in was about clarification between the difference between trauma, I guess trauma-focused CBT and CBTP. So trauma-focused CBT is obviously focused on trauma. It's an approach that allows us to train a whole team and a whole service in ensuring that the person, the clinicians and the staff team are aware of and able to respond appropriately to trauma. So a great model in that piece about being able to train a full team, but then also informing individualized interventions. And so the TFCBT would then be helping a client to process the trauma, usually re-narrating the trauma and identifying what are the specific areas to focus on as part of that trauma. CBTP, on the other hand, might be helping a person with specific beliefs that would be related to psychosis. And I see the person who asked the question then said seeing trauma as similar to psychosis in a way, and I absolutely agree with you. We, like I said, we're understanding a lot more now about psychosis and trauma and the links between the two. And certainly there's been some conversation about whether there is actually a kind of a trauma psychosis subtype. But I think where we are in this process is still trying to understand, first of all, the intersection, and then secondly, how do we appropriately address either trauma or psychosis? And I would say that it's imperative that staff team members are trained in the assessment of trauma, in understanding differential diagnosis between trauma and psychosis, and then really being able to work from a TFCBT or a CBTP approach to address either the trauma, the psychosis, or both. What we would say is if the individual is experiencing acute psychotic symptoms, we might want to help the person to stabilize before we address the trauma. But for many, many years, there was this idea that if you worked with trauma with somebody with psychosis, even with somebody with psychosis who was relatively stable, it was just going to destabilize them and become this catastrophic outcome. It was very fragilizing of individuals with psychosis, and there's been a number of studies now to show that is absolutely not the case, that we can certainly very effectively treat trauma in individuals with psychosis. And as a little plug, that we have a, what did we call it, Psychosis, PTSD, and Trauma special edition in the Frontiers journal that came out, I think, at the end of last year. And there's a number of different trauma and psychosis papers in that special edition. If you're interested, it's rather wonderful. And then I have another question about what are some other evidence-based therapy modalities for psychosis, which is a fabulous question. And in short, I would say the strongest evidence base that we have right now for individual therapy for psychosis is CBTP. We have emerging support for what we'd call kind of like the third wave therapies of ACT, and some emerging support for compassion-focused therapies. There haven't been as much research into those, probably because they're much newer and because they've been more newly applied. But those would be the two that would stand out to me as the other primary interventions for psychosis from an individual therapy approach. And then there are under CBTP as an umbrella, there are a number of different approaches. You know, we could think about group therapies using something like Eric Granholm's CBSST. You can think of formulation-based CBTP. I would see the IRT training and approach that is part of the Navigate model as really being under that CBTP umbrella as well, the individualized resiliency training, IRT. So we can also think about CBTP as being this umbrella term. And then the final question before I move on. So in reference to being collaborative, should natural supports and family be trained on the practices also? Funny you should ask that. So yes, I think so. We are beginning to see more studies looking at what happens if we train family members in some of these skills, and I actually have a workshop coming up a week on Saturday with a group here in Northern California, where we'll be training CBT skills to family members very similar to the things that you'll be hearing about today, but obviously adapted to a family setting as opposed to a professional setting. We don't want family members to become therapists, but because they are spending the most time with the individuals with psychosis, with their loved ones, it seems ridiculous that they don't have the skills that we have, say. So we really want to be thinking about what skills would help support that. And obviously there are a number of models for working with families around psychosis as well, but what we're thinking about is how do we get these skills directly out to the families. And there are other folk doing that too as well. Tanya Lecomte up in Canada, in Montreal, and Yulia Lander over on the East Coast are also doing this family work. All right, so let's see, 9:50 my time. I said I'd talk for 50 minutes and give people a break. So I'm going to suggest that we just have a quick 5-minute break and then just give time to like stretch your legs, that kind of thing, and then we'll dive into the kind of fun clinical stuff. So I'm going to go on mute for 5 minutes. Feel free to, I don't know, run around, do some jumping jacks, check your emails, whatever. But I'll start talking again in 5 minutes. Thanks. All right, so that was a 5-minute break. So let's get started again. And we're going to go into now sort of the clinical application of this model that I've already been talking about. So I already shared with you this acronym, this first model, forming a relationship, inquiring curiously, reviewing the information, skill development, and trying out the skill and eliciting feedback. And I'll admit to being somewhat grandiose when I pulled this together as well, because we actually initially developed this for our inpatient nursing staff. And it was my hope, and you know, you've got to set big aims and big goals, right? That after this training that they would use these skills first, see what I did there, before kind of reaching for the PRN meds. And so what we're trying to do is we're going through several series of training the nursing staff on the inpatient unit in this model is to evaluate whether that has actually kind of worked out as I was hoping, as my hypothesis states, and whether we're seeing a change in PRN med use through staff being skilled in using these techniques. So we shall see. Sorry, let me just, there we go, okay. So step one, as we talked about, is this idea of forming a relationship. We know that a therapeutic relationship and a poor therapeutic alliance can be predictive of poor outcomes. This was a study done by Goldsmith et al. Back in 2015, who analyzed data from the Psychosis trial, which was a large-scale CBTP trial in the UK. And when they looked at the individuals who hadn't done quite so well, they noted that their scores on their therapeutic alliance measures were much lower. And so the recommendation for that is that CBTP should only be delivered when a good therapeutic alliance is possible. But to me, what that really emphasizes is the need to spend time up front on developing that relationship so that you can then kind of have it pay out later, if you like. This might take longer if someone is very highly paranoid, for example, or has had bad experiences of services. Therapeutic relationship takes precedence over assessment and intervention, unless obviously there's risk. And then we'll really see the emphasis being on warmth, collaboration, and mutual respect. There may be a number of engagement issues associated with working with somebody with psychosis. Hello, that was moving on its own. And so we would want to engage around befriending initially. And we think about befriending as this sort of neutral discussion of non-threatening topics. We have no active formulation or treatment happening during this process. It's non-confrontational. We're being empathic, supportive, and accepting, but without being collusive. And we might also want to engage in assertive engagement techniques as well, particularly for those of you working in community settings. And this might be about, you know, meeting the client where they're at, going and meeting in a coffee shop, being in a library, in their home if possible, to really ensure that we are able to respond to the client's needs to support engagement. Examples of befriending might include, well, for me, I used to do a lot of community work when I was back in the UK, less so, well, none at all now I'm here at Stanford. I do everything in my office, unfortunately, and if I want to leave the office with my client, we have to sneak out the back door because technically it's not allowed. Don't tell anyone I said that. But there's lots of ways we can still engage here in the office, and so that often includes, you know, young clients particularly bringing their favorite pet. I've had dogs and cats in here. The cat was a bit of a mess. That kind of climbed inside the rubbish bin, but it worked. The client was very engaged after that chaos. It can also be about watching a shared movie together, or a shared YouTube clip, or talking about a favorite band and being able to listen to that between sessions so that as a clinician you can talk about it next time. So there are a number of different ways that we can really engage around befriending. And for me, befriending might be the first 5 or 10 minutes of a session. It might be the first 5 or 10 sessions, depending on the client and their presentation and how motivated or demotivated they are to engage in therapy. As we say, it's supportive and accepting, but we're also trying to avoid collusion, and I'll talk about that as we talk about questioning. But essentially, we think about collusion as going along with the client's beliefs when we ourselves don't believe them. So an example of that might be, well, come and talk to me today and stay in my office, because by the end of the day, I guarantee you the mafia will have stopped following you because they know me. So they're not going to follow you if they know me, right? It's saying something we don't have buy into ourselves and don't believe in a way to be kind of very manipulative. So we're going to try and avoid collusion at all costs, although as you'll see, we call it sort of balancing on the kind of the collaborative fence can be challenging at times, and we'll talk about that when we talk about questioning. We want to be non-confrontational, but like I said, we're trying to avoid collusion, and showing interest in the subject with non-judgmental questioning. All can be really helpful to support engagement. The pacing of the session and this sort of initial forming a relationship may need to be at a slower pace. We might want to use aids. So in my office, that's about having a whiteboard. Out in the community, it might be about having a pen and paper and being able to write things down if the client's very visual and finds it easier to track in that way. And we want to be aware of internal distractors that might impact the client's ability to concentrate. We're using word-perfect accuracy and consistency, so maintaining consistency throughout sessions, but openly acknowledge any inconsistencies from the therapist. So where possible, I'm trying to use the client's language. So if they're referring to their voice by a name, I'm using that name, if that's okay with the client. If they're using a neologism or a new word that they've created to explain an experience, I'll be using that as well. But if it's something I'm uncomfortable with, I will share that and check in that that's okay. So a really easy example of that is that I don't use the word schizophrenic. I don't refer to people as schizophrenic. But if a client's referring to themselves as such, then I will openly acknowledge the inconsistency and why I don't use that. They're free to continue to use that language. I'm not going to force them not to, but I want to be transparent as to why I'm not using that word, for example. And if through this process of befriending, we notice an increase in agitation or distress, we can move away from it. Having this befriending in our back pocket can be really helpful for later, because if we're beginning to explore potentially triggering topics, then we can use what we know about the client from this befriending perspective to move into these non-threatening topics or these more neutral topics. So, for example, I had a client who was very, very paranoid. We spent a long time talking about his love of dance music and his time on the island of Ibiza, going to the dance clubs there. And then as we got into talking about the stuff that was more triggering for him, if I noticed him becoming really activated, it would allow us to then go back to talking about dance music and any new songs he's listened to this week and what would he recommend for me. So having that in my back pocket if necessary. And then we can always agree to disagree on a topic. Being able to mutually respect that my client has one perspective and position and I have a different perspective and position, and that's okay. We can still have a conversation about the weather. I think can be highly modeling for then for demonstrating to the client how they can take that perspective and that position with other people. We don't have to believe and agree in the same thing. But it's okay to be flexible and creative, and that's where I really see the benefit of applying these skills in the community in the real world is, do this when you're out and about in I don't know, around the town or down in a shopping mall. I was in the DMV yesterday, and it was the most triggering experience I've had for a long time. I was using lots of CBT skills to get through my hour-long wait. And the best place to really practice this is in vivo. So being able to use these skills in the sort of day-to-day interactions with clients can be super helpful. So what do you guys do that encourages engagement with your clients? What are some of your sort of go-to befriending tricks and tips and tactics and strategies that you wouldn't mind me reading out and sharing? Just feel free to quickly type that into the chat. Like I said, I shared a couple that I have of pets and things coming in here. I once read the first graphic novel of The Walking Dead, which was a big push for me because I'm quite terrified of zombies, but I was willing to do that to engage with my clients. What other things? I saw a couple of people typing, but nothing came up. What other things do you do? So we've got coloring books, coloring to break the ice for adults and youth. Humor, absolutely. Shared humor is such a great way of being able to engage with a person and connect with them. I like to definitely draw upon my English background for a lot of that. We can also think about shared self-disclosure at a level that you feel comfortable with. Genuine curiosity about topics that they may enjoy and that you're not familiar with, absolutely. It's a great time to learn about this. I've learned, so much recently about, oh gosh, I'm blanking on the name now, but a specific computer game that one of my clients is into, and I've been able to really, I couldn't say I'd be able to play that necessarily, but be able to to understand at least the premise of the game, that when they're talking about it, I get what they're referring to. Using snacks, fabulous as well, and to develop rapport. I'll certainly use cookies or snacks, depending on the client, to reinforce behavior as well. Using knitting, that's awesome. I keep trying to learn knitting. I haven't been able to get to the class yet. It's been a bit of a, keeps getting cancelled. So maybe once I learn knitting, I'll be able to bring that into my practice. See, this is just a thinly veiled attempt to get more engagement ideas from you all so I can steal them. All right, thank you for those. I appreciate it. Another thing that we can do that can really support our befriending and our relationship is identifying a shared goal. And I've really started to emphasize this more recently, because when we, particularly working with the nursing staff, where they would come to me and say, well, our goals are so different. They want to get off the unit and we need to keep them here. So how can we work from a common ground? And so we started to have a conversation about it and actually discovered, and it kind of makes sense, right, that yes, the nursing staff and the people working on the unit want to keep the client on the unit, but they don't want to keep them there forever. So unless in certain settings that is the case, and I do train with forensic settings too, so that's different. But in a sort of a short stay inpatient setting, the goal that both people have, both the nursing staff or the professionals and the patient or the client, is ultimately to get off the unit. Now, how that's going to happen and how quickly that happens might quickly start to diverge from the shared goal, but it's much easier to start from a place of agreement than it is to start from a place of disagreement. So I'll think about this as sort of kind of rolling back until we can find a place where we can both agree and then start from there. And I find that can be really helpful for families as well, where it's very easy to kind of, with family shortcuts and shortcuts in language and assumptions and shared history, it's very easy to kind of roll ahead and go to the disagreement. And it takes some effort to go back to, well, actually, we all want to be happy or to be able to communicate together or to be more relaxed around each other. And it's kind of assumed, but it can be really powerful to have that stated. So in this like shared goal setting, we can, first of all, identify problems. They don't have to be symptoms. In fact, oftentimes the most powerful problems are not symptoms. The list should be generated by the client, and the clinician can add things, but do so collaboratively. So I noticed that, you've got school and your boyfriend on our problem list, but you haven't got the voices. Tell me about why that's not on there. Obviously, we would be dropping that collaboration if there were issues of risk and we really needed to pull our therapy trump card and say, yeah, that self-harm is going to have to go on our list because we're going to have to talk about it. We want our goals to be SMART goals. We want them to be specific, measurable, achievable, realistic, and time-limited. And again, just how we did about socializing the client to the model, I'd be socializing them to this idea of SMART goals. In fact, oftentimes clients have already heard about it and will educate me around this. But really trying to highlight that what we're doing is moving towards a specific goal, and it's the goal that we'll be able to measure and that we're going to be able to put a time limit around that so we can sort of see the progress. Like I said, with shared goals, what we're doing is trying to think about how do the goals of the therapist and the goal of the client, or the goal of the professional and the goal of the client, align. So what do we want to both work towards? Finding the shared goal and work from there. And like I mentioned, it's helpful in supporting alignment between the family. Just pausing for a quick question, would shorter time limits be best? Yes, I would agree with SMART goals that we want to have something that doesn't feel so far off that it loses its meaning. So if the goal is, I don't know, I want to be an astronaut, for example, it's not a very smart goal, that's years down the line. But passing the physics test that I've got coming up in the next 8 weeks, and I'm finding it really hard to study, is going to have to be a goal that we get in place before we become an astronaut. So that might be a goal for 8 weeks, for example, to improve my ability to study in physics from 30 minutes a day to an hour a day, 3 days a week, and the next 8 weeks would be a good time-limited SMART goal. So I certainly think that we're trying to keep these short time limits so that we can be checking in repeatedly. The second step in this process is this idea of kind of inquiring curiously. And within this, we think about sort of normalizing and questioning. We think from a normalizing approach, I consider CBT to be an inherently normalizing in and of itself. So quick check, you don't have to type anything in, but just kind of reflect on your own experience. We all experience negative or unhelpful thoughts from time to time. I know I do. We all engage in unhelpful thinking strategies. We might do some mind reading, we might do some predicting of the future, we might do some black and white thinking. But again, it's really common. And we all use strategies that aren't always the most healthy choices. Long, stressful day today. I could go to the gym, probably will have a glass of wine instead. So, not always the healthiest choices. So we see these as like the underpinnings of CBT, and it's something that we all do. So essentially, anybody could and should be able to benefit from CBT and learning some of these skills. And I think this is a really important message for working with psychosis, where people have often been told that you need something special, something different, something other in terms of a treatment. And here we are going, yeah, let's just do this CBT thing that, anybody would benefit from. And I also find it helpful to sort of share how many of the kind of great sporting greats that are among us these days have benefited from sports psychology that really is based in CBT to improve performance, to think about how a person's thinking about their performance, the tools that they use in terms of visualization and stuff, have very strong CBT underpinnings. So here's a non-mental health area that benefits from CBT, so emphasizing the normalization. But we also want to think about normalizing psychotic symptoms as well. And we think about normalizing as being the antidote to catastrophizing psychosis, which is often the case. It takes us back to this idea that psychosis exists on a continuum, which we've talked about already. But if you think about how psychosis is really conceptualized in society and promoted, unfortunately, by the media, it's as with very negative and frightening kind of very stigmatizing methods and means. So we want to take this normalizing as a way of avoiding the catastrophizing, recognizing that mental illness is a common experience. Psychosis can affect anyone regardless of age, ethnicity, gender, and socioeconomic status. Large numbers of people can overcome symptoms. It's funny, though, that never makes headline news, unfortunately. It's all the other stuff that does, the small percentage of other experiences of psychosis, and that symptoms may be viewed positively in different cultures. We're trying to normalize the experiences, not dismiss them. So we want to check in as to how this information is being received. If it's being seen as invalidating, then we certainly don't want to for that to happen. So I'm not saying that you're coming in and saying, well, I totally get that you're hearing voices because, one time I heard my cell phone ring and it didn't. That would be a pretty invalidating message. But what we might do with a normalizing approach there would be to check into how common do people think that hearing voices is, and how do they believe, or what is their experience of, or what's their understanding of people hearing voices? Is it this kind of self-stigmatizing message that all people who hear voices can't work, or that they're crazy somehow, using kind of air quotes there? And can we normalize that experience and actually help the person to recognize a whole host of different experiences around voice hearing? So that gets us into like the how do we do the normalizing. We might be encouraging people to research and read personal recovery stories, people like Alan Sachs, John Nash, Ellen Longden, Rufus May. It's a great list and it's an important list, but it's a problematic list in some ways because that is a list of overachievers. Nobel Prize winners, Ellen Longden's a double doctor, Alan Sachs, a USC professor. Important to recognize these individuals because it shifts the pendulum in public perception, gosh, I wish I could speak, from this negative stereotype to something more positive and more reality-based. But it might be hard for clients to really engage with that list when they are so far removed from as mere mortals. So it's also important to help a person engage in recovery stories of people who look similar to the person that you're working with. And here I always talk about helping the agency develop a library of recovery stories, perhaps. So people in the local area, that anonymized or not, talk about their recovery from psychosis. There are things online. I think On Track New York has a whole host of recovery stories, videos that you can access. Timetochange.org.uk, again, has a number of different recovery stories on there, all with the aim of sort of engaging around this idea of normalizing. And if you have lived experience of psychosis and that's something that you're comfortable with, this is a great opportunity to be able to share that and draw upon those experiences and allow the client to ask questions around that too. So we're not trying to minimize the experiences or dismiss them. We're trying to decatastrophize them, and we're showing that the clients, that they have experiences that are more common than they and many clinicians would realize. A quick pause for a question about repeating the sources that I referenced, which I'm going to try and remember now. I think it was On Track New York has a number of video, and I'm sure it is them, has a number of video recovery stories. And then timetochange.org.uk is a mental health charity in the UK that has a whole host of recovery stories for every different type of mental health problem, and psychosis and schizophrenia are on there too. So if you were all in the room with me right now, we'd be pausing to do this as a kind of like small group discussion. But I'm going to have you sort of think through this for a second. And then if you are comfortable, type in any experiences that you may have had and that you're willing to share that I can share with the group. And we can talk about why we're doing that after the exercise. But I find it's really helpful as part of this training, and it's what I do with clinicians. It's what I do with family members as well. Is to just think back to times when you've had stuff that didn't make sense, that you had an experience and you kind of scratched your head over it and you're like, well, whoa, that was kind of weird. It might be perceptual experiences, times when you thought you heard or saw something, times of feeling suspicious or paranoid, any beliefs in the supernatural or alien encounters. I love those stories. Anything around sleep deprivation where you've noticed kind of just feeling a bit off the next day or out of body or hearing or seeing things. Anything related to drug use. An example that I like to share, I've got lots of stories around this, as you can imagine. I collect these constantly, either my own or other people's. But for the interest of time, I'll give you the shorter one rather than my long, protracted one. But for example, I was having a massage recently, and I would have sworn my massage therapist asked me if I wanted to go for a coffee after, in the middle of the massage. And I was just about to respond and say, well, no, that's a bit weird. And I was like being very British and trying to figure out how to turn her down, when I suddenly stopped myself and thought, I don't think she actually said that. I think that was an auditory hallucination. And it makes sense in the context of kind of the altered state of being in a massage, being very relaxed, almost falling asleep. But you can imagine that that totally ruined my massage, because I spent a lot of time after that thinking about how I just experienced this hallucination and what it meant and how I could incorporate it into training and talk about it and use it for normalizing. So I should have probably got my money back on that massage, I reckon. Anyone got any other examples they want to share where, you know, just kind of like scratched your head, watched a scary movie, and then spent the rest of the evening checking behind the curtains and under the bed just in case? Any ghost stories or, gosh, I don't know. Yeah, aliens. Have you seen any aliens? Lots of people are typing. This is awesome. I'm excited. I can't wait to see what's come through. It also gives me time to drink my cold coffee. Let's see what's going to come through. Lots of people are typing, but nothing else, nothing came through. More people are still typing. Maybe people are just typing really long stories because it's such awesome Here we go. This is a nice long one. And I'm going to make the assumption that if you've typed it out, you're going to be okay with me reading it out. Unless anybody, I'm going to make that assumption because if you weren't, you wouldn't have typed it out there. So we have somebody talking about working for an early intervention program for psychosis, awesome, who discloses the 2 psychotic episodes in their 20s, which is fabulous. Thank you for doing that and doing that work. One of what derailed life, leaving grad school, took me years to get back on track to where I am. It helps me to relate to some of what they might be describing and also to let them know that it won't always be like this. So it's so incredibly powerful to be able to have that narrative as part of the services we provide. A belief that seeing a double rainbow meant everything was going to be okay following a tragic death in the family. And that's a really beautiful one, and thank you for sharing that, because to me that gets along the lines of, you know, such a healthy coping strategy and such a healthy way of responding to something. And yet if we think about it from a psychosis perspective, we would see that as being magical thinking, and we would be tempted to pathologize, and we shouldn't be pathologizing. We should be recognizing this wealth of experience. After days of not sleeping, putting food in the freezer instead of the microwave, and believing someone would come into the home and taken it. Oh yeah, I can. What's the word I'm looking for? Oh gosh, empathize with that. You can tell I'm having a few days of not sleeping thanks to my toddler's cold right now, so I feel like I'm on the verge of this. Thank you so much for sharing those. So the reason why I do this exercise, and I do it in full trainings, those of you on the line who've been in my trainings have been exposed to this previously, is because I think it's really helpful and healthy for us as clinicians to connect with things in our own lives that haven't made sense and how we responded to them. Helps from that empathic perspective. It helps us to also kind of engage in that curiosity and to sort of question and to think about that, and to think about how, if we'd have shared that information, or if we did share that information, how it was responded to and how that was helpful or not. So I find it really useful, and plus it's always really fun to hear people's experiences. So it's a way of developing empathy, having examples to draw upon as necessary as part of this normalizing component. And we think about normalizing as really further strengthening the relationship through shared experience as appropriate, providing the information to the patient about their symptoms, but really decatastrophizing from I am crazy, which is so incredibly loaded in our society, to this is an understandable reaction to. So we can think about, you know, what we've got up there, the double rainbow, meaning everything would be okay following a tragic death. That's a really understandable reaction to a bereavement. And I think if we start to see psychosis as being an understandable reaction to, it again allows us to create those relationships a lot better. So this takes us into this questioning piece around, you know, how do we ask questions? Now, traditionally in the CBT model, some of you will be familiar, I'm sure, is this idea, this phrase called Socratic questioning, which is essentially a therapist being incredibly clever, having an answer in mind, using really smart questions that then gets the client to come up with that idea, and the therapist can sit back and go, oh, I would never have thought of that, while feeling all smug inside because you've got your client to say it instead of you telling them, because we know if we tell people to do stuff, it isn't very effective. So Socratic questioning can work really well if you're good at it, and if your client doesn't call you out on it, as one of my clients always does. He's like, oh, you're using that questioning again, just tell me the answer. I'm like, okay, you're right, you got me. So actually what I find to be far more valuable and high yield is using what Christine Podesky would term guided discovery, and I call kind of curious questioning, because to me it gets more to the kind of the underpinning drive of being just really curious and really just trying to understand what's going on here, and tell me more about that. So Socratic questioning takes you to an end goal. Guided discovery is guiding the client towards their own discovery. And curious questioning I see as being part of that. It's just kind of like figuring out with the client and asking questions and trying to understand what previously has been very hard for the client or other people to understand. So being curious, number one. I say that I got into this job because I'm just nosy by nature, and by being able to sort of ask questions all day, means that when I go home, I'm not, twitching the curtains to find out what people at number 32 are doing because I've used up all my curiosity during the day. So kind of thinking about like your really like nosy relative who you've just met at Thanksgiving, they just won't drop it. Oh, what are you doing now? No, for work, what are you doing? Like they just keep asking you questions. You're like, oh, no, no more. Obviously, we don't want to be hounding the clients, though. We're trying to check our assumptions and make sure that we're not making assumptions, and if we are making assumptions, noticing that and dropping them, and being transparent about that. So, for example, a clinician I was supervising, I was listening to their tape, their client was seeing, she was a clinical high-risk client, she was seeing shapes and shadows in her room and was frightened by this. And the clinician made the assumption that she was frightened by this because, it'd be kind of scary to see things in your room that aren't there and, is it going to do me some harm, that kind of thing. And so she went along that line of questioning as if that was the truth. And eventually the client was like, no, I'm not scared of it for that. They can't hurt me. I'm scared of it because my grandma used to see stuff and she was crazy. That's what's really scary. And so the assumption that the clinician made had set them off the wrong path. The client was kind of smart enough and the relationship was good enough for the client to be able to correct them. But it was a nice example of how our assumptions can really drive us, and we have to recognize when that's happening. We're trying to explore all the possibilities in this process. So, for example, we might be, as we're sitting on this collaborative fence with the client, asking them how they understand a certain situation, and then saying, maybe offering a different way, like, well, could there be any other ways? Like, if that happened to me, I'd be wondering, could that be aliens? Or could it be a ghost? Or could it be my brain playing tricks on me? Kind of throwing out all these different things so they're out there on the table, not saying that you buy into any of them, but just recognizing that there are these different ways of seeing it potentially. And be curious, ask questions. I'm often asked whether there are any questions that we shouldn't ask. And the first time I was asked that, it kind of made me pause because, oh my gosh, I don't know. Are there any questions you should never ask? So I don't think there is a question to avoid. What I would say is the questions have to be relevant. So, asking a client about whether they're flying on a private jet to go on holiday or not is not relevant unless you are doing a phobia, some sort of intervention around flying, fear of flying. Gosh, English is hard sometimes. So if you were doing an intervention around a fear of flying phobia, there we go, you would want to know if it was a private jet, and you would want to know what the interior looked like and how swanky it was and what was in the cocktail cap. Maybe not that part, but you'd want to know everything about that plane possible so that you could really develop the intervention. So it has to be relevant. And the other piece is obviously if you're noticing that asking the questions is leading the client to disengage, to become more triggered, to become distressed, then we can back off. We can go back to the befriending. We can recognize, hey, I'm sorry, I didn't realize that that question was going to be such a tough one, and just really owning and being transparent about that. The question here, appropriately, about how do we keep the questionings focused. And so I had a client who thought he was sent by God to save the world, and because I asked questions, he took that as a sign that I was sent to help him. That's great. Okay. So I think what that question is getting at is how do we keep the questioning focused, but how do we also avoid collusion? And again, I'd be really transparent. So in an example like that, if that's what the client was sharing, like, well, you asking questions shows that you're obviously you've been sent to help me, I might share, actually, I have a different belief system, and we can or we can't get into that. It's up to you, and there's things I'm going to be happy to share about that, and there's things that I'm going to be less happy to share about. But, I don't see myself as being sent by God to do this work. You might. That's fine. I don't. So we might have different perspectives. It doesn't mean to say I'm not interested in your perspective. It just means that I don't share that belief. And then we become, like we said earlier, that agree to disagree perspective. Is that okay that I have a different belief system about God than you do? And can we still work on our shared goal despite that? And if we can't, then we need to talk about that, because that might mean that we're not going to be a great fit for each other. I typically don't have to kind of get to that piece. Let me pause for a second and just ask if there are any questions about questions. We're kind of getting meta in our questioning. The other thing that people sometimes will share with me, I'm just sort of anticipating any thoughts or questions you might have, is there the possibility that by asking and by exploring all of these different impossibilities, that you might end up giving the client a delusion or giving them an idea or a thought that they hadn't already. Oh, right, I didn't think it was aliens, but now I do. I'm out here. I'm definitely aliens. My response to that is, one, I don't think I have sufficient power to create a delusion in somebody. The other thing that I think about is that it takes me back to thinking about how when novice clinicians learn to ask about suicide and that fear of like, well, if I ask about it and they weren't thinking about it, am I going to give them the idea to do it? And there's kind of like a sense of responsibility about that. And we know that that is not the case. We know that suicide risk assessment does not lead into suicide, that by not asking about suicidal ideation, we're doing a client a far greater disservice than by asking about it. And so I think about that in the same respect with asking about a person's delusional beliefs or about their voices, or about really understanding, is that we aren't going to create it. What we're doing is uncovering and understanding what a person is already thinking. And it might take place over a number of sessions and over time. It often takes time to unravel this. Oh, and then another question is, if answers to questions tend to change over time, is it helpful to revisit questions and point out the change in thought? I think so. I will, if there are changes, I might say something like, well, gosh, it's funny, because when we were talking about this last week, we thought it was this, and now we're talking about it this week, and it seems to be like it might be something else. What happened? What changed? Have you got new information I didn't know about? Or, have you been thinking about this differently? Have you got different evidence? Like, help me understand that. If the client's sat there saying, well, no, this is what I've thought all along, that might give me a clue that we need to track the information a little bit better, make kind of shared notes together so that we can keep on the same page and keep track of the information. But I would certainly acknowledge inconsistencies and explore them, because it's all great information for later. So then how do we review this information and pull it together? So actually, before I keep flicking backwards and forwards, let me pause again, sorry. So this questioning, if we think about how we're doing this in a sort of a real-world setting, I would see this as being an opportunity that if you're out with a client, maybe taking a walk around the park, doing some engagement with them, maybe some physical exercise or some socialization, and the client starts to become sort of visibly distressed and visibly anxious, this is an opportunity to really ask questions about that. So, hey, Mr. Smith, just noticed you got really scared when that person came past. Your eyes got really wide, you look like you're shaking a little bit now, and you were kind of like trying to hide behind me. What's going on? What did you think? What did you think when you saw that person? What did you notice about them? Can you tell me about how that fits with the experiences we've talked about before? So it's an opportunity to really explore and use our questioning in the moment. Obviously, if the client is able and willing to do so, we might want to engage in some strategies to help them calm down before we ask about it. So, gosh, you're getting really activated and anxious. Let's use some of that breathing, and then when you feel ready, let's talk about it a little bit more. So we want to know. So now we get to review the information and pull it together. There's a couple of ways that we can do that in this sort of like CBT-informed skills way. One of them is the stress bucket, and this is really based on the idea of the stress vulnerability hypothesis. And underlying this is the idea that we all experience stress in our lives, obviously, and we all have varying degrees or varying capacities to manage that stress. And that degree or the capacity to manage stress can change from time to time as well. And so what we might talk about with the client is just how much stress do they have in their stress bucket. So what's in their stress bucket right now? How full is it? What happens when it overflows? When it overflows is when we typically see symptoms getting worse or a person really being unable to cope or deal with those symptoms. We could then talk about what are some helpful and unhelpful coping strategies a person uses to manage their stress, and we're doing that initially in a very non-judgmental way. We just want to know what are the things that you do that bring the stress, that you do when you feel stressed? And then our final piece of exploration is talking about, well, which of those inadvertently adds back to your stress? So even though you're using the coping skill to bring the stress down, which one results in you actually feeling more stressed in the long term? So an example of this might be a client, this is based on a client I had a little while ago, who was hearing voices, he had his exams coming up, his parents were arguing, and he was applying for college. And so his stress bucket was pretty full. And so, what he would do is he'd talk to the voices, stay up all night playing video games, and go for a walk when he was feeling really stressed. Looking at those strategies sort of non-judgmentally, we identified that going for a walk didn't really have any downsides, any unanticipated consequences. But talking to the voices or talking back to the voices and staying up all night playing video games did, because it meant that he was too tired to really study. It meant that he wasn't studying. When he was talking to the voices, his parents would hear and they would yell at each other about it and tell you who should be helping him. So he could hear them having an argument about what they should do about the fact he was hearing the voices, and so he would talk to the voices more. So you can see it would kind of get into a really sort of nasty cycle. And so, we negotiated initially that he would play a video game for 1 hour and then try studying, for example, as a way of still using the strategy, but seeing if we could cut off that hose that was taking the stress back into the stress bucket. And so this is again just a really easy visual way of helping a client recognize current stresses and ways of coping. And again, can kind of be done on the fly, can be done when we're out and about, can be done in kind of very brief settings. We don't need hours and hours of therapy interventions to develop one of these. And it can be helpful for then helping sort of the frontline provider, a case manager, peer provider, whoever, to identify, well, what are the skills that we really need to help this client develop in order to manage when they become overwhelmed and stressed. But we can take this and make it just a little bit more complicated because, why not? Using something like maintenance formulation. So here we have, my interpretation got wiggly there, sorry. Kind of very similar to what I showed you at the beginning, which is that thought, the cognitive triangle, the thought, the feeling, the behavior. But underlying this one is a recognition that beliefs are sort of instrumental in how we see the world and view the world and interpret the world and react to the world. So an example of this, let me kind of talk you through this case example, would be you meet Sam at the library. He looks very anxious and describes an experience this morning where he could hear talking. He concluded that this was his neighbors talking about him, making threatening comments, leading him to believe that he was not safe. He became very afraid and anxious, and instead of doing his laundry as he planned, he stayed in his room all morning. So if we think a little bit about the information we've gone through already, this would be an opportunity to really use our curious questioning. Actually, if we step back a bit more, we might see that he's really anxious. We might need to use some of the befriending, talk about a book that he got out last week, how he's enjoyed it, help him to calm down a little bit, falling back on that relationship. Then using our curious questioning to understand why he's presenting as so anxious and what happened. What did he hear? How did he make sense of it? Where was he? What did he end up doing or not doing? And then we can pull that information together. This is the R of first, reviewing the information, pulling it together into this mini formulation. And here for Sam, what that looks like is he hears a threatening voice. His interpretation is that my neighbors are talking about me. He becomes scared and anxious, stays in his room and isolates, and underlying this is the belief that I'm not safe. Now we can be really flexible in this as well. So it doesn't have to look like this. In fact, mine really, sorry, I'm knocking things over as I'm moving around. Mine rarely look this beautiful except for when I'm presenting. They tend to look kind of quick and dirty, drawn out on the whiteboard, on a piece of paper, the client drawing it. And it's going to depend on where the client is at in terms of their engagement and their ability to make these connections. So for some clients, we're not going to go with the belief yet, or we may never go that deep. We might not identify the belief. We might just have thought, feeling, behavior. For some clients, as we're building up to this and working up to it, we might just, first of all, make a link between I hear a threatening voice, I feel scared, and then so I stay in my room. We're just making a link between the event, the feeling, and the behavior. So there's the opportunity to be really flexible based on what the client is able to access and tolerate. But ultimately, what our kind of goal would be to develop something like this. I just want to pause and see if there are any questions about this formulation before we move on. All right, I'm going to take that as a no. What this allows us to do, other than having something that looks incredibly pretty if it's drawn out like this, is then to identify where and what can we intervene and what level can we intervene at. So, having done something like this with a client, I personally prefer to draw it out because I like that ability to step back, for the client to step back, for us to agree that this makes sense, that it fits, that it explains the experience. So there's something about being able to put it down on paper or on a whiteboard and to look at it and to go through that process. But if necessary, we can do it verbally as well. It's like, oh my gosh, it seems like when you heard that threatening voice, you thought your neighbors are talking about me, you got really scared and anxious, so you stayed in your room and you're isolated. And all this kind of comes from this belief that you're not safe. Does that fit? And that kind of gives us that verbal. But like I say, I really like to draw it out, because then when we're drawing it out, we're also asking the client, so, okay, if we agree that this is what happened, and we agree that that's a problem, what can we change? What can we do? Where can we make some changes here? And we've already said we know that it's not easy, in fact, probably nigh on impossible to just change the emotion of, clicking our fingers. So do we need to explore whether that my neighbors are talking about me as an accurate belief or not, or an accurate interpretation? Do we need to address this behavior? Do we need to develop some other coping skills beyond staying in the room and isolating? We can make a guess that he might be staying in the room isolating and worrying and getting really anxious because he's continuously kind of replaying this in his head, or he keeps hearing the voice and he doesn't have ways to sort of to calm down. So is it about learning some skills there? We can't change the voice. We can't, well, medications might be able to, and we might be able to through exploring the link between thoughts, feelings, behaviors, and beliefs. But we can't immediately just make the voice change, just like we can't make a parent stop yelling at the child unless they're in therapy with the child, with the young adult. So the event is probably going to remain the event. What this allows us is to make changes potentially at thought, behavior, and belief level. So I want to just kind of give pause for just for a couple of minutes to see if people would be willing and able to just think about a client that you're currently working with and what emotions they have that they're struggling with. So fear, anxiety, low mood. When they're triggered by an event, what thoughts do they have? This could be psychosis or not, but given that we're talking about psychosis, it's probably best to stick with that. And then what behaviors do they engage in that maintain the problem? What I find often is that people, when I'm working with clients, that they want to go to, well, I use my breathing. Like, great, but something else happened, or else it wouldn't still be a problem, or that the breathing wasn't sufficient. So what is the behavior that they're doing that makes this a problem? Is it avoidance? Is it isolation? Is it getting into a huge argument? Is it rumination or worry? And then can you think of or identify any underlying beliefs that might be driving this? And so just kind of giving people a couple of minutes to think about that, and then the opportunity, if anyone's brave enough to come online, so I am not the only voice that you all heard this morning, and just to talk through that. Now, you could be doing sort of a verbal formulation because I don't have the technology or capacity to type this in, I don't think. Maybe I do. Do I? Maybe I do. Maybe I don't. Ooh, no, I don't. But, oh yeah, that's why, because it's, but yeah, just have a quick think about a client that you're working with and what that looks like from a formulation perspective, and if anyone's willing to join with, to share that with us. Get some free consultation. I'll give people a couple of minutes to just think through it. And I'm imagining you're all out there in the world, all across the United States, drawing formulations out as we speak. A mass formulation. Very exciting. Oh. I'm finding very cool things that it's going to let me type, apparently, I think. How am I going to do this? Yeah, look at that. That's kind of cool. Awesome. So I'll be able to type the formulation into the, what's this thing called? Computer. There we go. Oh dear. As we're sharing. All right, so I gave people kind of 2 or 3 minutes. Anybody have a formulation that they would care to share? You could either type it in or you could be unmuted. I think we have the technology to do that, and you can share it verbally with us. I see a couple of people typing. Okay, so Lisa's saying that she might have an example but doesn't know if she can fill all the boxes. That's fine. I can help you fill in the boxes. That be okay, Lisa? Do you want to? Would you? Okay, and Lisa's going to type rather than being unmuted. That's fine. We can do that. Awesome. So Lisa, go ahead. If you can just type really quickly. What is, maybe call on each person to speak, just let me know. It's okay, I'm technologizing over here. Lisa, what would be the event or the triggering event for your client? And I'll do some typing over here. Is sharing the office the triggering event? Oh no, that's your personal triggering event, I see. So I have a client who hears voices, they seem louder when she's alone or upstairs. Awesome. So I'm going to put in here, hears voices, while Lisa's telling me some more. And the interpretation, awesome. Oops, kind of can see that. Hears voices, what did we say, louder when alone or upstairs, awesome. And then down here, we've got interpretation is that there are people in the attic. Yeah, perfect. And then she's got strong anxiety that people from high school want to come get her because she's a horrible person and has done horrible things. So there are people in the attic. So then I'll let Lisa continue to type. Lisa, how does she feel? What's her emotion? Is it strong anxiety? Okay, so and then Lisa's saying the thing is, and I don't know how to incorporate this, but she knows that when she's with others, that she doesn't hear the voices. So as Lisa's giving us some more information, I'm going to put anxiety over here. Let her just say that. And I'm going to assume that you can all see the typing that I'm typing, the words I'm typing on the screen, even if it's not the most, yes, we can see, thank you, most legible. Okay, so then, and then Lisa's saying, but the anxiety is so great when she's around other people that she's bad at communicating and that people don't like her or just pretend to be nice to her. Okay, so that's awesome, because that's a good example of how this can then link to other situations and events. But for the sake of simplicity for this formulation, let's keep it to how anxious she feels when she's in the house alone and hears voices. When she's upstairs or alone and hears voices, she gets very, very anxious. Her interpretation is that there are people in the attic, and an additional interpretation is that they want to harm me, or they are coming to get me. I can't remember what Lisa typed. And so what does your client do when, what's her behavior? And while Lisa's telling us what her behavior is, she just deals with it. Okay, she stays in her room and watches TV. Okay, so then my question to Lisa's client would be, how is this a problem if she's able to deal with it? How does this continue to be, how is the anxiety maintained? And I would wonder if she ruminates on what Lisa already told us, which was she believes that she is, oh dear, where's my box gone? I am a horrible person. I have done horrible things. If I could spell that correctly. Does that work? It's kind of on there. So I'd be wondering and asking and exploring with this client if, along with sort of dealing with it, staying in her room and watching TV, if having this belief of I'm a horrible person and have done horrible things leads her to ruminate. She's extremely self-deprecating and probably feels like she deserves the fear and negative feelings. So my guess over here for another behavior would be that she would be engaging in some rumination. And as Lisa said, self-deprecation, that there'd be some self-criticism. So kind of like, I deserve this. If they do come and get me, I deserve it. What we should spell. Yeah, that's okay. It kind of fits. So what we've got here, and thank you, Lisa, there we go, yeah. So I'll share that in a second. So what we've got here from Lisa is this event where her client hears voices that are louder when she's alone or upstairs. Her interpretation is that there are people in the attic, they want to harm me, and they are coming to get me. She feels incredibly anxious, which makes sense. She says she deals with it, she stays in the room and watches TV, but what we're hypothesizing, what we're guessing here is that there's something else that maintains this anxiety. And so we're saying that she's probably engaging in some rumination and some self-criticism, some ideas around like, I deserve this. And then what Lisa also just shared was that the voices also tell her how horrible she is as well. And so we might even want to put this up here in the event, is that she hears the voices, and then specifically she doesn't, I can't do it, just hear the voices, but she hears the voices telling her she's a horrible person. So you see how it becomes very consistent. This would then also allow us to start to think about, well, how do we help her have less anxiety, but then also what Lisa's sharing is that this is the lesser of two evils for her. She prefers to be alone with the horrible voices versus interacting with people because she has such bad anxiety with other people when she's around others. So for her, being alone with horrible voices is better than being around other people because she gets so anxious. So if we're taking this as our kind of initial way in, what we might be wanting to help this client to do, and as we start to talk about developing skills, is stepping back and saying, well, gosh, if it's the lesser of two evils and you're still really anxious, it'd be really nice if we could find a way for you to be less anxious even when you're hearing these voices. And I wonder what we could do to help break this cycle, to help find a way out of this. And we have, if there's any flexibility from Lisa's client in questioning whether the people are in the attic, if they do want to come and harm her, if there's any way of doing an experiment around that, we could explore that. Or we could look at the behavior and help develop some skills, knowing that rumination and self-criticism is really reinforcing this cycle. It's a safety behavior. She's isolating, well, her isolation is the safety behavior, but when she isolates, she's ruminating and self-criticizing. Or we might want to identify this belief of being a horrible person and see is there a way of helping her to, what's the word I'm looking for, develop an alternative belief around that. And Lisa's noting that they've already identified that you can't even physically get into the attic, so that they've tried reality testing, which is great to do behavioral experiments like that. What I always think about this is that that's something that might need to happen repeatedly over time, and how does that information land and stay relevant? So the person might be like, oh, yeah, you're right, nobody can get in the attic. Yeah, silly me, in the moment, but how do we make sure that doesn't decay? So we're thinking about how can we reinforce the understanding that physically that belief isn't possible. How can we help the person remember that when they're really anxious? Because when we're anxious, we're going to default to the stronger belief, the more established belief. So how do we shift so that the belief of there are people in the attic is maybe like 80% and people can't physically get in the attic is 20%? How do we strengthen one and get the other one to come down? And that is often about repetition. All right, so I'm going to thank you very much, Lisa, for sharing and being brave to do that. And look at that, we did fill all the boxes, which is awesome. It's 11 o'clock my time. I'm going to give us another sort of 5-minute break to run around, stretch your legs, whatever you need to do, grab a quick coffee, whatever, and then we'll start back up at 11:05 my time. So in 5 minutes, and this time I'm actually going to make a note on the public chat, so anybody who's kind of elsewhere will see that when they come back and not hear blank noise or whatever you all have. So 5-minute break. All right, so let's get restarted. And we are now on to the fourth step of this first model, which is skill building. And skill building really builds off what we just discussed, which was the formulation. And so you could see with Lisa's client, what we started to think about was how would we then take that information and use this in a way that would inform our interventions. And so using a formulation like that allows us hopefully to identify interventions that are going to be high yield and really pertinent to the client, rather than just reaching into our CBT toolkit and throwing the first intervention that comes out at the client in the hope that it sticks. There's certainly some merit in doing that and knowing all of those different skills, but what I find is formulation allows it to be much more individualized. So thinking about this skill building and going back to the formulation that I had with the case example of Sam, he said he hears a threatening voice, my neighbors are talking about me as his interpretation, he stays in his room and isolates, he's scared and he's anxious, and his belief is I'm not safe. Before I think about the skills associated with that, I want to just introduce this idea to you around why it's not necessarily, what's the word I'm looking for? Why it's not easy, let's say that, to change a position or to change a belief, or for an individual to change a belief. So if we take, for example, Sam's position and Sam's belief that people are talking about me, if we were to be effective around our intervention and we were able to help him change his mind about that, there are these four possible positions that he can be in. One is that he believes that people are talking about him, and they are, and they actually are talking about him. Well, he's not safe. That's not a safe thing, and he's going to do all sorts of things to keep himself safe. And that's the place that he believes he's in prior to going to therapy, right? If we as therapists are somehow, or as professionals, somehow very cleverly able to convince him that they aren't talking about him, but it turns out that they actually were, so this is the bottom left cell on the screen, so I don't believe people are talking about me, but they actually are talking about me. Now I'm really not safe, because now I've stopped doing all that stuff that I was doing in order to stay safe, so I'm really exposed and vulnerable. So that's not a good place to move to. If we look at the top right cell, I believe people are talking about me, but they're actually not talking about me. Well, in Sam's language, as we did this a while ago with him, that would mean I was crazy. And like I've already talked about, that's not a great place to be from society's perspective. So there's a lot of stigma and a lot attached with that label. And so that's not a natural place to want to move to either. I don't believe people are talking about me, and they aren't talking about me. Well, that would be great, is what Sam said when we did this. But that's only one of four possible cells. And there's a possibility of falling into any of those others, which are not great places to be. So to me, what this really highlights and emphasizes is how difficult it can be to move and to change beliefs, how protective our beliefs can be, and how it creates a lot of empathy for me, from my perspective, of how certain beliefs can, like I said, be protective and be a very safe place to stay. So I like to keep this in mind, and this is also something, again, that I share with family members when people are just saying, well, he's so scared of X, wouldn't it be better if he didn't believe X? Well, sure, but not if the alternative is I'm crazy and I need to take medication for the rest of my life, and it means that my life is over and I'm never going to get a job, which is not what we say in terms of recovery. But if that's how a person's internalized their diagnosis or their experience, well, I think I'll take the alternative for many people. So it's useful to think about this process as we're thinking about some of the skills that we're building. So a very traditional, I wonder if I can, how I get rid of that now. There we go. A very kind of traditional CBT intervention is to explore the evidence. Remember how I said it's not about challenging thoughts, but rather exploring them. Here we have Sam with a little bit of wriggle room, who believes that the people across the hall are talking about him, and he believes it around 90%. So we know that there's 10% of him that has some doubts. And we'd want to explore that. What is that 10%? Well, maybe it's this, maybe it's that. And that gets us into our evidence for and against. Oops, where have I gone? There. So what Sam might say, I always start with evidence for if I'm doing this exercise because I think it's very validating and people often have a lot of that and you want to hear what it is up front. So for Sam, the evidence that the people, or his neighbours rather, who are talking about him is that they said his name, that he feels very afraid when he's around them, and that he's heard shouting from that room before. Then we want to spend some time and, collaboratively trying to think about, well, what's the evidence against? What's that 10% doubt, if there is some doubt in some wriggle room? Well, they've never actually directly spoken to me. The noise he hears is a whisper and not a shout. And when I recorded the voice and played back the tape, there wasn't anything there. And so what you see with this evidence against is actually something that was developed over a number of interactions or sessions. So figuring out how loud would the sound have to be in order to hear it from his room to his neighbours. And if it's a whisper, then how is that happening? And that kind of raises more questions than it does answers, which might take us back to our curious questioning. And also setting up this behavioural experiment where, and this was something that we did with Sam, which was he went home and recorded over a set period of time, came back to session, having made a note of when he heard the voices, and we then listened to that tape to hear if there was a voice on there or not, and what that would mean if there was, and what that would mean if there wasn't. And so again, emphasizing that collaboration and that sitting on the collaborative fence piece, I had a lot of, I was very transparent and really put it out there, if when he played that back to me and we heard his neighbours berating him and saying threatening things, well, that'd be up to me to act, because that's not cool, that's not good for him. So we'd then have to problem solve, we'd have to think about what we're going to do, that he's living in this threatening environment. So that was my commitment to the outcome. On the other hand, if we were to play it back and we didn't hear anything, what then would be his commitment to the outcome? What would that mean? What would he then have to do? So we set all that up beforehand and had that documented. And so this evidence against was when I recorded the voice, played back the tape, there wasn't anything there. The commitment to the outcome was that would then be taken as evidence that it wasn't people talking about him, and that in fact, and we go down to the alternative here, the alternative possibility is I'm hearing an auditory hallucination. Or as a current client I have, her alternative possibility for very similar experience, to be fair, is my mind's playing tricks on me, which is fine as well, as a good alternative possibility that she can get behind and connect with. So then we want to reformulate and reconnect this. So next time he hears a threatening voice, he can walk through these steps himself. Again, remember that this is about him becoming, clients becoming their own therapists. So next time he hears a threatening voice, the steps are that he can take a pause. He can say to himself, well, actually, I'm hearing an auditory hallucination here. I've got some skills to deal with that. I can use my deep breathing. I can reassure myself. I can listen to music. And I can change that underlying belief from I'm not safe to actually the voices can't hurt me. They never have. They are hallucinations. They can be mean and say horrible things, but they can't physically do the things that I'm afraid of, which is part of that reassuring self. Any thoughts or questions on that? That's a very quick gallop across a very quick gallop through sort of exploring evidence in a CBT perspective, but it's one of sort of high-yield CBT strategies. Any thoughts or questions? No? Awesome. What I will say, and I always put this as a caveat as well, the reason why the 90% is there is because there's some wriggle room. I personally, and I think others would agree, don't find this to be an effective strategy when there is absolute conviction, because it would be like looking at evidence for and against whether my eyes are blue. They're blue, by the way. You can't see that. That's the downside of the webinar. So if there's no buy-in to exploring the evidence, there's not going to be a whole lot of point doing an exercise like this, and then we might want to come in to the problem through a different route. So, for example, maybe coming in through the behavioral route. But this is a really great high-yield exercise when there's a little bit of wriggle room, a little bit of doubt, or maybe no doubt, but the willingness to explore and to see if there's going to be something else. Like, oh, you know what, I'm 100% sure, but I'll go along with this. And let's see what we come up with. I'll take that too from a client. Like we've talked about, there's also the opportunity for behavioural interventions. And so where there isn't the ability for wriggle room and there isn't the ability to sort of explore those cognitions, we might want to think about behavioural interventions instead. We think about these as sort of existing in these sort of like three categories, from distraction to focusing to metacognitive interventions. Distraction is the one that's the most commonly used and the most commonly taught. And I think about it as a great entry-level coping skill for voices. So here, you know, it might be about listening to music, playing guitar, playing music, shifting my attention. So that is what distraction essentially does, is shift your attention to something else that's going to be hopefully captivating. Doing art, going for a walk, engaging with your pet, watching a DVD, or I guess streaming these days, playing computer games. All the things that our clients often come in already having, or might need more tools under their belt to use. And I think about it as a sort of entry level because it's great in a lot of ways, and if people don't have those skills, then we need to help them learn them. But the trouble with them is that they're kind of a band-aid, and they're not always portable. So if my go-to strategy is to stroke my cat when I'm really distressed, well, that's not going to work when I'm in the mall and I haven't been able to bring my cat with me, for example. So we need others. We need to have a range of these strategies. We also think about it as distraction, like I say, is kind of being a band-aid, and it doesn't kind of get to the root. So it's great in the moment, fabulous. Like, we want to help people to feel less distressed, and if distraction is going to do that, let's do it. But if we keep having to use the distraction, it might tell us that we're just really just kind of using the band-aid over and over again. So what's the next level? The next level might then take us to this idea of focusing. So distraction takes us away from the voice. Focusing actually encourages the client to focus on the experience. Here it might be something like subvocalization or deep, slow breathing, like I'm focusing on this, I'm using some of my breathing, responding rationally to the voice. And that might be something that we'd want to coach the client in. How do I respond rationally? How do I respond assertively? Or working on schema. What do these voices represent, for example? I know Deborah Lampshire talks about her voices from the sense of really being very present when she's anxious. And so being able to recognize them as such, like, oh, these voices are here because I'm anxious. I need to check in with kind of what schema is being triggered around this. And then the third level, and kind of the harder to attain level, is these metacognitive strategies, using detached mindfulness and acceptance. So recognizing that the voices are present, accepting their presence, and being able to kind of, I guess, detach from that experience and function despite the presence of the voice. I also might put maybe some of the compassion-focused strategies under metacognitive, because again, what we're doing is accepting, recognizing the potential role of the voice, and then addressing that in a way that would encourage self-compassion. And it sounds somewhat counterintuitive when your voice is being, or the voice is being threatening or mean or derogatory, but encouraging the client to be compassionate to the voice, because if we're encouraging them to yell and shout back at the voice or be mean and nasty, this is an internal process. There's been some people that would hypothesize that as being kind of very toxic for the individual and just perpetuating low mood and distress. So what would kind of a compassionate response look like? I have a question here asking if these interventions should be used if the client thinks of the voices as friends or protectors. And I'd actually go back a stage as to whether or not they should be used. My question would be, how are the voices, if they're friends or protectors, a problem? And if they're not a problem, then no, we don't need to do these interventions. If they are a problem because, you know, they're friends and protectors, but the client is engaging with them all the time to the detriment of other activities, then it might be more about changing the functioning. or it might be about looking at the interpretation. Like, I engage with my protectors because they are nicer than anybody else I engage with on a day-to-day basis. Well, actually, that'd still be a behavioral intervention, because that might clue us into the fact that we need to help that person engage with other people in the world that are going to be meaningful and helpful. So I wouldn't be necessarily, if the voices are not a problem to the client, I don't think we need to change anything. So our number one question, which goes back to that shared goal, is, well, where's the problem with this? If you're hearing voices and they're friends and protectors and they help you get through the day and they give you good advice, great. Let's do that. Let's go with that. Eleanor Longden, who's got two fabulous TED Talks on her experience of hearing voices, talks at one point about how her voices were helping her do her exams one time. And so they were helpful. And like, great, let's leave that. Now, her voices have also been incredibly horrible by her account. And she's found fabulous ways of accepting and understanding their role and being able to respond to them. But if they're not a problem, we're not going to try and change anything. We can also, like we said, collaboratively explore the beliefs, and here we can develop a behavioral experiment. Again, if we think about doing this sort of at the front line and out in the community, we really want to be doing these experiments out in the world. You know, my office is lovely. I wish you could all see it. There's great pictures on the wall, and it's very cozy, but it's not the real world. Even I've got to accept that. And so, you know, if we're going to test out our beliefs around the experience, then we need to think about how we can do that in a place that's really meaningful for the individual. We're going to try and develop experiments so that they're win-win. It has to be about a belief or a behavior that's important to them, and we should also try to take into account all the things that can go wrong with an experiment, not always possible. And we should be prepared to consider the possibility that the belief is correct and what you, as the professional, is going to do. So like I said with Sam, if he'd have come back and on that tape that had been, or on that recording on his phone that had been evidence of the neighbours berating him, then I'd made the commitment to, well, we're going to have to do something about that. We're going to have to talk to the housing manager, because that's not going to be okay. So up front, we're prepared to consider the possibility that the belief is correct. This is an example of what a behavioural experiment sheet might look like. There's no right or wrong way really of doing this, but I do always recommend having it written out ahead of time so that you know it's really well planned and you can come back to it afterwards and check in. Because it's hard for people to remember. So, well, you know, what did we say? You believed it 90% or 95%? What do you believe it now? So we want to have that tracking component. And this is an example of what we talked about with Sam. So he was going to use his MP3 recorder to record the sounds in the room for 1 hour, write it down every time I hear people talking. Likely problems, I might not hear anything, so strategy would be to try again another day. He might forget, we wrote down a reminder and he kept it on his computer. The expected outcome was that Kate and I will be able to hear the voices on the recording when played back in session. And I have a video which, through the power of technology, we are going to have played. There, look at this, it's amazing. All right, so this is a video, just if we pause it before we play, of a role play between, you'll see Doug Turkington there on the left. He's one of the original developers of this model. He wrote the book along with David Kingdon called Cognitive Therapy for Schizophrenia. And on the right there is Ali Brabham, a highly skilled CBTP therapist and proponent of CBTP in the UK, and does tons of training and really involved in early intervention in psychosis. So it's a role play. Doug's playing the client. He nearly always plays the client, which is always very entertaining to then be the therapist trying to therapize him, because he's got many ways of trying to catch you out. But what you're going to see here is Ali and Doug exploring a belief that he has that his thoughts are being sucked up by satellites and transmitted to other people, so that other people can hear his thoughts in that way. And overall, Doug's being pretty good, so he's not giving Ali too much of a hard time. So it shows the kind of the development of a behavioral experiment in this way. All right, press play, please. Thank you.
So I've just been hearing about this belief that everyone's hearing your thoughts, that they're kind of somehow being transmitted into their heads. And it sounds as though out of all the things that are going on, that's the thing that's most distressing for you, that other people can actually read your thoughts?
I could cope with all of the rest, but I'm really anxious. See, I'm sweating just now, and I'm really worried about all these people knowing my thoughts.
Right, okay. I mean, one of the things that I think we need to do is to try and get some more evidence, really, to find out, you know, what is really going on here.
Oh, I wish we knew.
Because it seems like there's something going on, but I'm not quite sure what it is.
Yeah.
So what I'd like to do is to try and do some kind of an experiment so that we can gather some more information and see what happens.
Okay.
So I'd like to think of an experiment in some ways that tests out whether people can read your thoughts. That's really the crux of it all?
That's what I want to do.
Okay. I'm just wondering if you've got any kind of creative ideas that you could think of that would find out whether or not people are, you know, that if I was watching, would know one way or the other, or find a bit more information about what's going on.
So we're both going to watch.
But I was just thinking it might be useful if I was there, because at the moment, I mean, how at the moment do you know that people are reading your thoughts?
Well, I stay in my flat a lot, as you know, because I'm a bit too scared to go out. But sometimes, maybe it's like once every couple of hours, I can feel it starting to come on.
Right.
And then there's the whoosh.
Yeah.
Thoughts gone, empty head, and it goes out. And I look out the window, and I can see that, like, there's one woman talking to another woman, and she turns her head away. I'm thinking, oh, jinx, I've gone out again.
So it's something about how people react at that time.
Absolutely.
Right, okay. So, any thoughts about what we might be able to do?
I think a really funny joke.
Okay.
But my thoughts aren't like that. My thoughts are mixed up and sad and shameful.
Can you think of something that would get a real reaction from people in terms of behaviour that we could observe? Something that, you know, there would be absolutely no questions about what was going on in terms of how people reacted in terms of behaviour.
Seen them actually moving.
That might be something that would be quite useful, yeah.
Well, suppose I thought that you know that band One Direction?
I've heard of them.
Suppose I say One Direction are about to open a supermarket in the shopping centre.
Okay.
Because, like, people go crazy for them.
Okay. So if you had that thought, anyway, what would we expect to see?
Well, I think some people will be disgusted because they don't like them.
Right.
But lots of people will be running to the supermarket, I think.
Right. So if I was with you and I said, right, you need to keep having that thought, we would see people running towards the supermarket.
You would definitely see some of the younger end of the market running.
Okay, then. Okay, so that would prove that people were actually getting that thought.
Yeah, it would.
Okay, if we were in that situation and people didn't start running, what do you think that would mean?
Might mean they don't like One Direction. Might mean they didn't pick it up.
Right.
Might mean they're preoccupied with their own thoughts. I don't know.
Right, because I'm just wondering if we're going to set this up as an experiment, we've got to think about how we're going to interpret the results when we see them. So I suppose that's one thing. It needs to be something that we're pretty convinced that if we don't get a result, there's a good chance it means they're not picking up your thoughts, if you know what I mean.
It needs to be something bigger than this One Direction thing, doesn't it?
I just wonder.
Like maybe some kind of super sale.
Okay.
Things are cut to 20% of their proper price.
Okay.
Really nice furniture and clothes and stuff.
Right, okay. And what would happen if people didn't run when they got that thought? What would that mean?
Well, I suppose that I'd start to wonder if the thoughts were going to them.
Okay, so it might make you wonder whether or not it was happening or not.
Yeah.
Okay, because it needs to be a valid experiment, I suppose. That's what I'm trying to get at. It's no good setting up an experiment if it doesn't really give us any more information.
But if it's not going to them, where are they going?
Well, perhaps that's the next thing to think about. So first of all, is it going to the other folks? And then the next bit is, well, if it's not, because we don't know, it might be that everyone starts running through the shopping centre and they say, in which case we're going to have to deal with that. But for now, I suppose we just need to look at that. So is there a certain time or kind of particular shopping centre we need to go to? Or?
Well, we can look at my window and we can see the shopping centre.
Okay, so...
It's every couple of hours this happens.
Right. So we could do it from your flat, and we could actually observe what's going on outside. And you'd be happy that that was a pretty decent experiment to test things out.
If you were there, that would really help me.
Okay. Okay, then shall we arrange a time then, and we can set that up?
All right, thank you for playing that. Appreciate it. And we're going to go back to the slides. And literally, we did our exercise, right, on like weird experiences that don't always make sense and make us just question for a second. As I was saying, and that is Doug Turkington on the left, he texted me. Ooh, da-da-da-da, kind of getting into Twilight Zone. So I thought that was quite funny. That'll be another example for me as to how did Doug know I was talking about him when he's in Newcastle and I'm here 8,000 miles away? Who knows? Anyway. So let's see. So I'm curious, as you know, a good curious questioner would be, as to what you noticed about how the therapist explored that belief with the client. So how did Ali talk about this with Doug? What kind of examples did you see of collaboration? Did you feel like the experiment was generated by the client or the therapist? And what do you think the therapist said that helps the client really engage in this exercise? So, feel free to just quickly type. But what did you, instead of making me do all the work here, I've been talking for 2.5 hours, what sort of things did you notice that really emphasized collaboration, that demonstrated this, that the experiment was generated by the client? What did you notice about how the client explored the belief and the therapist explored the belief and the kind of questions that Ali used? This is way easier when people are in the room and I can just give them Paddington hard stares until somebody actually speaks. All right, everyone's shy or exhausted by the 2.5-hour marathon and gallop through CBT-informed interventions. Well, just to reflect, and I could call on folks, but I feel like that would be really mean. I'm not going to do that. I'm going to let you all off. I'm hoping that what you noticed was that it was very collaborative, that she was using a lot of questions, and she was really sitting on that collaborative fence and really trying to explore and understand his experience. Monica's saying, thank you, Monica, that she asked him a lot of questions, and she does. She, before, she doesn't jump right in there with, hey, I've got this idea. Like, she really wants to understand the experience before they kind of go forward. She's kind of asking him, like, is that all right? What ideas do you have? What do you think we should do? So, trying to generate this from the client. And to the extent that they go down a path that you can see her kind of thinking, is that One Direction thing going to work? And then going enough for him to say, it needs to be bigger than that One Direction thing, right? And then he goes with this other thing about the furniture sale. And then you also hear her say, if everyone does go running, we're going to have to deal with that. But what's it going to mean if it doesn't happen? And so kind of really setting that up ahead of time as well. The final piece of this first model is this idea of testing out the skill and eliciting feedback. And so like I said, this is kind of like the homework phase, but we don't call it homework for obvious reasons, that for many people, homework has very negative connotations. It has ideas of kind of having to be forced to do something, not very well rewarded for doing something, kind of coercion. And so, not calling it homework, but calling it an action plan, calling it a skill or an experiment or an exercise for the week, just using shared language. Unless, of course, your client likes homework. I work with a number of adolescents that are really engaged in and around homework, and they call it homework, and they see it in that sense, and they add it to their other homework load, and they get it done. In that case, it's appropriate to call it homework. But use the language that fits. So we're trying to develop this in a way that the client can try out the skill that we've been discussing over the next week. So if we're doing something like a behavioral experiment, if we're learning coping skills, all of these things set us up really nicely for what you're going to do between now and the next time we meet, between now and the next time we grab a coffee together, or between now and when we meet for that appointment to go to the DMV. What are you going to practice? What's going to help you prepare for that? What about today are we going to really try out? Possibilities for homework are endless. There are many reasons why therapists or professionals might not set homework, but not being able to think of anything should never be a reason, because there's so many different things that we can do. Forgetting, for sure, not leaving enough time, definitely that happens a lot, but not being able to think of something, there's so much that can be done. So it's about applying the coping skills. Did it help? Was it help? What was helpful? Does it need to be modified? Can we gather some more evidence? So we've been talking about this today. We've been talking about the possibility of having people in your attic. Is there any evidence that we'd have to gather in order to continue that conversation next week? Would it be useful to know the size of your attic? How are we going to get that information? Can you go up there? Do you need to contact the letting agency? Like, how are we going to get this information? That'd be great homework. How does that evidence fit with their experience? If we've been talking about an alternative thought, what did you do differently because of the alternative thought this week? Or what can you do differently because of the alternative thought this week? What can we do to strengthen that alternative thought? How are we going to act now that that alternative thought's out there on the table? And if we're doing this, if we're setting this up and establishing it, we absolutely have to make sure that we check in about it the next week. Otherwise, think back to when you were at school, and if you'd have been set homework every week by a teacher and you handed it in and you never got any feedback, the teacher never even referenced it, you'd pretty soon decide to stop doing the homework and stop handing it in. So we want to reinforce the importance of this activity by making sure we put it front and center at the beginning of the next meeting. Like, hey, how did that thing go that we said we were going to try out this week? And because we're talking and emphasizing collaboration, we can think about this as being a two-way street as well. So the collaboration, the homework or the action plan or whatever, doesn't just have to happen with the client, but what are you as a provider potentially going to be doing over the next week that helps all of this go forward? Is it about, checking into the dimensions of an attic? One person's going to get some information, another person's going to get some information and pull that together. Is it about, I'm trying to think of homework that I've done recently. Like I said, like the engagement stuff, reading The Walking Dead. Or if we've been talking about maybe some cultural experience that I don't understand, but it's going to be really helpful to the conversation, then maybe I'm going to go away and read a passage from the Bible, for example, to further that conversation. So what can we buy into as well as a professional? I'm going to pause again just for a second, because we're going to start to sort of wrap this up and start to think about, again, how does this really land in the real world? But I just want to check as whether there are questions about the first model overall or anything that you've heard so far. Any questions from folk? We're doing fine on time. This is a great opportunity to start practicing that curious questioning. Or I can use my cognitive skills and reframe from my current unhelpful thought that everyone has actually fallen asleep to, no, I've just told them absolutely everything they need to know, and of course they wouldn't have any questions. See how you can apply CBT very effectively to yourself, if not somewhat maybe erroneously. I see some questions coming in. pausing while those questions get typed out. Goodness, it's a good job I'm a therapist and I'm comfortable with therapeutic silence. Okay, well maybe while people are typing, and actually what I'll encourage, because we're going to have some time at the end for questions, be typing now and be thinking about those so that we're not having to do too much of the silent treatment for you all. And then we'll come back to these questions. I'll do this slide and then we'll come back to questions. So for any of you wanting to sort of queue up some questions, get them in there. So just to kind of look at this kind of last slide before we get into the Q&A, is to think a little bit more formally about how these CBTP-informed skills can land in the real world. And so there's lots of opportunities to integrate these skills into your work. So if we're thinking, I don't know if there's any medication providers on the call, but excuse me, it's a great opportunity to draw upon CBT skills to discuss medications, to be really curious about the experience of taking medications or not wanting to take medications, and to recognize any potential assumptions around that. For example, working with a young woman right now who doesn't want to take medication, she's clinical high risk, and the psychiatrist is recommending some medications for her anxiety. She doesn't want to take them, and it was only through really asking her lots of detailed and careful questions that we determined that her reason for not wanting to take them was because if she improved, she wouldn't know what was her and what was the medication, and she had a lot of questions around sort of identity and autonomy. So that made a lot of sense within that context. But it would have been easy to have assumed that it was stuff like, well, side effect profile and toxicity and all the stuff that we typically hear. We can look at barriers to taking medications, and like I said, through this process, any thoughts and beliefs about taking medications, and then draw upon the skills that we've already discussed to maybe have a discussion with the client and engage in some shared decision-making around medications. Incorporating support CBTP informed skills, into supported education and employment. So when I've worked with individuals who are trained in IPS or in supported employment and talked about these skills, where we've really sort of emphasized them is around sort of difficulties completing homework or procrastination around work or school or around organization. So again, if we're thinking about procrastination as an example, what are some of the thoughts that are associated with that? What we see with procrastination is a lot of permission-giving thoughts often. And here it's sort of helpful for the C worker to identify those permission-giving thoughts, and using something called the 3 Cs, catch it, check it, change it. We want to catch when the permission-giving thought is floating around in the person's head, check whether that's actually a helpful or realistic thought. And we could say pretty much it's not a helpful thought because it's just going to lead the person having to doing the work right up to the deadline, being really stressed, working till late at night, and then changing the thought. So if the permission-giving thought is, oh, you've worked all day at school, you deserve 4 hours on the computer, you can do this later, then changing it to, well, let's see, an alternative helpful thought might be, yes, I've worked hard at school, I can give myself a 20-minute break on the computer, then I'll get my work done, and the rest of the evening is mine to do with what I want, for example. Can use CBT-informed skills with peer providers. So where clients, like as an example, a client's anxious socializing potentially, going out into the world with the client. I think I've given this example already, really asking questions around the anxiety and the triggers for the anxiety, what the person noticed, what they're experiencing, using that to really pull together the thought, the feeling, behavior, and then trying to see what can we do about that. And then the same applies working with family providers too, or working with families as well. So what is the examination of family stress? How does family stress contribute to the individual's stress? And how can we potentially use some of these skills to decrease some of that stress? And then, like I alluded to at the beginning, and I left these slides out, I think it's probably a good idea I did, because it takes us down a whole different rabbit hole, and it's another long piece of work, but we can think about how to apply these skills to your own health. Now, obviously, you're not forming a relationship with yourself, but maybe sort of some befriending and being kind to yourself is good up front. But I think taking the opportunity to sit back and think, well, why am I feeling really overwhelmed right now? Why am I feeling sad or anxious? Asking those questions of ourselves, being curious about our own experience, recognizing our thoughts and our behaviors. So, if I'm feeling really overwhelmed at work and I'm thinking I'm never going to get everything done, I need to focus on this, my behavior then might be to, the behavior might be then to snap and be irritable with people. And recognizing all of that process is happening allows us then to identify some skills to deal with it. So I need to take a break, or I might need to do some deep breathing, or I might need to really center myself before I go and collect the next client, for example. So how do these skills really apply to your own mental health as well? The best therapists are the ones that can also apply the model they're using to themselves. So that's sort of an example of how this can and should land in the real world from the perspective of different roles. I've seen some questions coming in, so that's awesome. So I'm going to spend the next sort of 10 minutes answering those. But do feel free to keep typing questions, and if for some reason I don't manage to get to them, I can always email in response. So one of the questions here is, do you think it's helpful to go back every month or so with a client to review the experiments and outcomes to highlight improvements or weaknesses? So yeah, sure. I think it's very helpful to keep tracking this. And I think part of the question of how to track will be kind of from the perspective of what is important to track over time. So for example, I've been tracking with my client her anxiety in a specific situation that she was really keen to be able to manage. And each week she's been doing that thing, that situation. And we've been tracking her anxiety in different time points during that activity over the last 4 weeks. And we've got a nice graph now that shows this reducing over time. So I think, having a way of tracking, having a way of showing progress, whether that's weekly, whether that's monthly, really then helps to relate that to the goals and helps us to know, are we on track with the goal? Do we need to change the goal? Have we achieved the goal? Are we able to terminate therapy? Is there something else we need to work on? So absolutely, I think tracking is a really, really helpful tool with this. Another question here, how would you work with a youth who has protector personalities with command hallucinations for suicidal and homicidal ideation / gestures? Trigger event appears to be anxiety any time we are close to disposition. Oh, I think that's another webinar in and of itself. So how would I work with this individual? If we apply the first model, I would initially ensure that we had good rapport, particularly given that there are command hallucinations. And as part of that process, as the person was getting engaged with me, I'd be curious as to whether the command hallucinations was referencing myself as a therapist, and if so, how we were going to deal with that. Often clients will report that hallucinations, command or otherwise, will have a lot to say about therapy and about the therapist, and I'd really like to know what that is so that we can talk about it. That obviously is dependent on the relationship. It'd be interesting, given that you've already identified that the trigger event appears to be anxiety anytime you're close to a dispo. I would wonder if the client has any insight or awareness of that, and if not, how could we track in a way that might show that pattern or might highlight other patterns? It sounds like your hypothesis, which is great, and it's good to have those. So how can we do some tracking that shows maybe an increase in this or an increase in suicidal behavior, homicidal behavior that links to this, and then kind of asking the question, like, well, why might that be? Why does that occur? And is there a pattern around the command hallucinations as well? And then what we could get into, depending on where the problem is, the problem, the protective personalities, the command hallucinations, the risk, is maybe engaging, and this is taking us out of CBT-informed skills, this is taking us into full CBTP, but using a cognitive therapy for command hallucinations protocol. Max Birchwood has done a lot of work on that and has written on that extensively, which is a sort of a very stepped model for working with command hallucinations, which involves a lot of exposure, because what we often see with command hallucinations is the need or the urge to act on the hallucination is very much linked to how powerless the person feels in relation to the hallucination. So it's often a lot about exposure and trying to shift that relationship with the voice, trying to shift the power differential so that the person starts to feel like they have more excuse me, choice and autonomy over what the client, what the voice is saying or telling them to do. Okay, and then here's another question that the majority of the youth that this person works with refuses to take medication because they've taken it so long and they feel like it doesn't help. And yes, absolutely, that's very, very common for us and as well. And so I'm very lucky in that I work with a really great team here. I love working as part of the team. I'm definitely a better clinician because of that. And so if I was working with a client who had that belief and that question, what we might start to talk about collaboratively in a shared decision-making model and slowly over time, test that out. So if that person's absolutely convinced that it's not helping, then do we need to take time off the medication? And what would we be tracking during that period? So it's not just that the client's going to stop meds, but rather we're going to change over time. We never just stop a medication, right? We taper. What sort of signs and symptoms would we be looking for over that period? And if we started to see anything emerging, what are we going to do? What's our plan? So I'd much rather do that with a client collaboratively than have them just decide to stop meds on their own at home without any support and kind of setting ourselves up potentially for a crisis. So if I have a client who's really adamant about that, that is one direction that we might decide to go to. But there are other strategies that don't have to feel quite as extreme. Another example could be doing a timeline review. So if the person's had periods of time where they've been on and off medications, doing a chart review, discussing it with the client and with key support people to say, well, what was going on when you were taking this med? What was going on when you were taking the other med? What was going on when you were not taking meds at all? And what about now? And I literally draw that out as a timeline and put key events and key symptoms on that timeline so we can stand back and go, it's interesting, when you're on that med, this all seemed to be happening. This med, those things seem to get better. No meds, oh, that was interesting. On these meds now, this. So we can see that change. Because, youth, psychosis, general population, our memories suck overall, and we don't necessarily recognize change. So often clients will say, well, it doesn't feel like anything's helping because we haven't been able to recognize and track an improvement. So going back in that way might draw attention to those changes. And then one last question here. Can you share how one's sensory sensitivities or one's misinterpretation of sensory input influence their hallucinations? And do you consider this when, kind of cut off, oh no, further down, when applying interventions within the CBTP model? Yes, indeed. So how does an individual's sensory sensitivity or misinterpretation of sensory input influence hallucinations? So I think there's two parts to this question. So I think that's a kind of jury is out kind of question, in that we know that how people process information at a sensory level is certainly influential in how we experience the world, including how we interpret hallucinations. And so that might be one possible alternative explanation we would want to help a person towards. So try to think of a young man I was working with who had a lot of sensory processing challenges, and he would actually only hear an auditory hallucination in one ear, which was interesting and kind of atypical. And his distress around it was actually more about, it wasn't so much what he was hearing, but it was rather, if somebody, it was like a false positive, if somebody comes up to me and tries to talk to me on that side, and I think it was a hallucination, I ignore them, I'm going to really offend them. So it wasn't so much about the hallucination and what it meant, but rather what it would mean if he got it wrong. And so we kind of really thought about how he processed the world and how his known sensory processing difficulties influenced how he engaged with people and how he could draw upon those skills to then overcome that fear of, is it a hallucination or is it a real person? So I think essentially it builds into the formulation. And what I hope that you're hearing today, I'm trying to convey is that when we're using CBTP, we're really not trying to pathologize the experience of psychosis. We're trying to understand it from the perspective of the individual and then identify what we can do to help with any particular problems. But if there aren't problems, if this isn't distressing, if it isn't impacting functioning, then we're probably not going to be applying CBTP. Okay, let me see. So we're at 5 minutes left. That gives me time to do the logistical stuff. I'm supposed to mention the next webinar that's coming up on the 20th of April, 12 till 3 Eastern Time. And that is Understanding Psychosis Using Formulation to Develop Effective Interventions. So it's taking, what we've done today is this kind of CBT-informed skills. This next webinar is really taking a deep dive into the formulation piece. So that maintenance formulation, that mini one that you saw, we'll look at that in some more detail, but we're also going much, much deeper as well. Excuse me. And then I meant to tell you about the survey that will somehow magically appear somewhere, maybe in your inbox, maybe on here. Here we are, in the public chat. Please take the survey as we finish up. And with sort of 3 minutes left, I guess I will start